models. I hand over this proceedings to Dr. Abhay Nene, sir.
Thank you so much. And thank you, Alchem, and thank you, Spineway, for getting us together. We've just created this event out of the schedule. We thought that while everyone is chilling and just trying to get back to life, we'll do some academics. And we've created this group called WeAreSpine Focus Learning, where we'll take up one topic and thrash it down to the detail. And today's, just to get the expectation setting right, today's take home or your learning objective is going to be that you're going to learn the principles of correcting a simple AIS curve. So all the words are important. We are not talking of rigid curves. We are not talking of high degree curves. We are not talking of non-AIS curves. So there are lots of principles that we thought that we should exchange views about. And this, hopefully we've kept a very small group because it's going to be hands-on also a little later. And hopefully we want to make it very interactive. So I think first rule is that everyone try to sit in the front benches. The back benches come in the front because we want to try and involve everyone in the discussion. And actually you're going to come up here and tell us stuff. And this is a closed room meeting with only us. So there's nothing like a stupid question. Just ask whatever you're afraid to ask, and don't feel shy about something you didn't know and you should have known, right? So we're going to break this down into two parts. The first will be two didactic lectures, which are only alluding to techniques. We are not going to talk of principles, just techniques. The first one, I will talk about posterior releases just to warm up. And then Dr. Harshal Bamb will talk about the corrective techniques, which you will be then using on the models. And after that, the plan was to get into the house and start some interaction with y'all. And we'll do some case discussions, like x-rays, and ask you all to give your comments on the different strategic vertebrae, what your planning would be like, etc. Because you can't do technique without basic planning. Though this is not about planning, we need to warm up about planning. And then we'll get on the hands-on and then, finish with lunch. I think that is the plan for now. So, as far as principle of AIS correction are concerned, we all know these. A good pre-op planning is critical, and unfortunately we're not going to dive deep into pre-op planning today, though you can on your own ask questions and something you don't understand. But our agenda is not pre-op planning. We're going to cover it in a soft way. So generous soft tissue release and bony releases are now getting more and more important. So in the past we used to think that with instrumentation you can pull things together. But now we realize that the instrumentation has a limitation, and it can cheese out, it can cut through and cause a lot of problems unless there's a good release. So principally, releases are important. That's why they've earned one separate lecture for today. Strong anchors. So if you can't pass screws in the spine, you can't be doing scoliosis surgery. And no matter how you look at it, a bad screw can't be salvaged. If you have a bad screw, you can't get a good correction. So you have to get your drill of passing screws in the lumbar adult spine over and over and over before you think of passing screws in the pediatric normal spine in cases like TB, and then you go to deformed spine. So we will show you some rules of passing screws, but you have to be absolutely proficient in passing rigid screws and good anchors in the spine, because if the screw is bad, everything else, which is salvage, hooks and cables, and is really, a very, very poor second. So you have to get good screws to be able to execute all the techniques that you're learning. Of course, the correction maneuver, you will learn so many maneuvers today, but you need to know which one to apply when, because a correction maneuver applied at the wrong place can, fall on your face. And of course, in the end, construct should be stable and there should be a good fusion. And as orthopedic surgeons, you've always learned this, that the spine is different from a long bone, because a long bone was designed to be one unit. The spine is designed to be a mobile structure, and we as surgeons are creating it into one unit. And hence fusion becomes the cornerstone of any successful surgery. Within your limited experience, you'll have not seen pseudoarthrosis, but as you see more and more cases, you will see how pseudoarthrosis can require a very funky resurgery, because it's not easy to do resurgery in a pseudoarthrotic scoliotic spine. And just right now we're dealing with one in our clinic. So a good fusion is a cornerstone. So as far as releases are concerned, here's the good news, that your first release happens the minute the patient gets an anesthesia. And how many ever corrective x-rays you'll have seen, traction x-rays you'll have done, the minute the patient under anesthesia, there's a deep muscle relaxation, and the curve falls into place. And then the minute you offload the patient lies prone. The effect of gravity is lost. There's another bit of release. And in the end, once you do a good paraspinal dissection, the muscles actually detach from the spine, and whatever dynamic scoliosis is there goes away. So invariably a curve that looks like that on the x-ray will start looking like that once you expose. And this is a common joke in all live surgery seminars, that once you open the scoli, "Arey, ye to seedha dikh raha hai." And it's really because your primary 3 releases have happened even before you said good morning. Okay, so remember that all these are important. Your positioning of the patient is important, correct anesthesia technique is important, and release of the paraspinal muscle has to be absolutely complete. And it has to be a cadaveric dissection, not only for a good release, but to get your landmarks right, so you can get your screw insertions right. So don't leave any soft tissue there. The next is the interspinous ligament. Many of us tend to skip it because when we pass screws, we don't need to meddle with the interspinous ligament. But the minute you take the interspinous ligament off, you will get a much better view of the vertebral column, and you'll see where the spinous process is actually tilted. A lot of times the interspinous ligament is bunched with a lot of soft tissue which overhangs, and you don't get to see the tilt of your spinous process. So strip it dry. Just pull it, strip it dry without taking away the bone, so you can actually visualize how the spinous process is aligned. We are sometimes shy to take away the yellow ligament because then you start seeing the dural structures. But coming from a background of sublaminar wiring, we've always been taking away the yellow ligament. And if you see good surgeons across the globe, they take away yellow ligament for a scoliosis case. There are two things about this. One is that the yellow ligament is known not to be a restrictor of derotation. So the yellow ligament has fibers which are very, very flexible, and hence any maneuver is not restricted by the yellow ligament. So if you didn't take the yellow ligament out, you would still not really, just like the disc. If you don't take the disc out, it really doesn't matter. You can still do a correction maneuver compared to, say, a overriding facet. But on the other hand, if you want to do a Ponti release, which we are always doing now, you need to take the yellow ligament out. So it's in your interest to learn and get used to taking the yellow ligament out. So after the interspinous and the yellow ligament, the next thing you want to do, which a lot of surgeons miss, is taking away the facet capsule. So a lot of us are trained at putting pedicle screws from the lateral side of the facet, which is the right way to do it. But here you want to expose the facet, not only take down the capsule, but also do a facetal osteotomy at every level. There is no good reason not to do this. So there are 3 things that you acquire by doing a facet osteotomy, aside of erasing the facet capsule. The first is you get a great release because the facet is invariably crookedly aligned. And the minute you take away that overhang, the shelf, the facet starts moving much better, sliding much better to give you a good correction. The second thing that you achieve by doing this is you get bone graft, right? You get precious bone because these days you're not normally harvesting from the ASIS or from the PSIS. The third thing you get is better delineation of the anatomy, exposure of the facet to get a better fusion. So there's no good reason not to excise the facet joint. Dubara mat puchna. There is no discussion on this. There's no reason not to take the facet joint at every level before you pass the screws. Ideally, before you pass the screws, because after that, the head of the screw covers the facet joint, and then you're struggling, right? So that's the kind of release that you want. Now, after this comes the Ponti osteotomy. It's a fancy name actually for an extended yellow ligament release. So when you take the yellow ligament out, what you do is that you take away the layers of the interspinous ligament and you reach the yellow ligament. Now, remember, this yellow ligament is a bunched up, it's a layered ligament. It goes in multiple layers, one on top of the other. So it looks like a bunch of tissue. You got to take a nibbler and thin it down. So slice it down and take away the layers till you actually see the cleft in the midline of the yellow ligament. So the deepest layer of the yellow ligament has a midline cleft naturally. It's just that that has been covered by double breasting, and hence you don't see it. So when you thin it down, you'll actually, the dural fat will peep out, and then you put a ronger and centrifugally start cutting the yellow ligament laterally. As you do it on the left and on the right, you'll hit bone, right? When you hit the bone, that's the bone you want to remove to do a Ponti osteotomy. So that's simple as that, right? So Ponti osteotomy is actually making it into a, pars release, if you may, like converting creating a rattler, if you may. But the picture in the center shows you what we're doing. We're just going, centrifugally from the midline laterally. The picture on the left shows you what minimum you need to do. So as you see here, typically this is a thoracic facet. So this is the inferior articular process of the superior facet, which you must remove. Okay, now after you do that, you will find the superior articular process of the inferior bone or inferior lamina staring at you. you actually want to take that down also and then look at the raw nerve root at the bottom. And that is a true ponte. So you've actually taken away all the bony resistances on the side. And then you've got a good release, and you'll see how the, how the mobility actually improves. And those are some intraoperative pictures. And hopefully we'll demonstrate this on the model, but there's no yellow ligament on the model. So please look out for this cleft. When you thin down the yellow ligament, which initially starts looking like this, it'll start looking like that. And only then you want to put your ronger in. And then, as discussed, take away initially the superior facet, the inferior facet of the superior, and then the superior facet of the inferior. We borrowed these pictures from the AO manual, which is available freely online. So you all can, look into it. Now, here's the key question that once you do this is the inferior facet osteotomy. There's no problem because you have not visited the neural structures. You have not, invaded the spinal canal. You still cause some release. But if you took this down, you'd get a better release at the cost of visiting or exposing the nerve root and the spinal canal, and along with his epidural bleeding. So the two complications of facet. So basically the question on top, how much facetectomy is enough or how much ponte release is enough? That question was never asked when the ponte osteotomy was invented, if you may. But then we realized that there are three big disadvantages of the ponte osteotomy, and you need to know those because then you know where to temper it down and not just do it everywhere. So the first is epidural bleeding, and those who've done it will realize how pontes bleed, and that can be nasty bleeding. One of the ways to curtail that is to use an ultrasound bone chisel, and most surgeons across the world are using ultrasonic bone chisels to do the ponte osteotomies and not osteotomes or forward rongers because it tends to stop bleeders. That's my personal experience also. The second disadvantage is that the neural structures get exposed. So there is a possibility of neural damage. However careful you are, we've had a situation where we did an osteotomy and the fragment flipped, and it not only caught the root, it caught one side of the central canal, and the patient had a transient deficit post-operatively. And that's known world over. So when you do an osteotomy, it's easy to see in diagrams. Think about a concavity of a scoliosis where everything is crowded. You really don't have visuals there, and it's kind of a blind over the top osteotomy. And when you do that, if the fragment flips in, you can have trouble. So that's the second big disadvantage you got to watch out for. The third is pseudoarthrosis, because you create such big clefts that intraop picture will show you these kind of clefts. And if you don't close them, which often you cannot in a rigid curve, you can have a higher incidence, and it's been documented to have a higher incidence of pseudoarthrosis. So with these three disadvantages, if you want to be a defensive surgeon, you can do only a superior bone excision or an inferior articular process excision as seen here, and leave the superior articular process intact, because there you're leaving continuity of bone, you're not exposing the neural structures, and there's no question of bleeding, right? So that is the question about how much is enough, and you can decide whether you want to do a partial or a total, right? I hope that's clear. Any questions on the ponte osteotomy? Anyone has any differential thoughts, Harshal?
So what is the extent? So in a normal AIS, how many levels do you do pontes?
So ideally, the more the better. So that question applies to all release maneuvers. The more release, the better it is. You got to get a, so how we look at it is that we have to release the apex. If everything is going smoothly, you start doing up and down also, even the compensatory curves. But I think every apical level, so the minimum you want to do is the apical concavity. The convexity is not that critical, but it's good to do because it helps you pass your screw better also. And then the compensatory curves, of course, because you're expecting them to come in line, so you want to do them. But the minimum is the concave apex, and the hardest is the concave apex. The hardest place to do a ponte osteotomy, as you can see here, is the concave apex. So try to do as many as you can, but don't miss the concave apex. Anything else? Any technical questions? This table, that table? Abhishek, anything you want to ask? Yeah, so that's another important question, and I was about to come to that. The best time actually to do it is when you've exposed everything and the raw anatomy is in front of you, right? So there are 3 times when you can actually do this pontes, and the third is the best time. So the first is when you've done an exposure, not done any instrumentation, all the bone anatomy is in front of you. It's very easy to do it. The problem is that now you've exposed the neural structures, you've started bleeding, and that's going to continue through the process. So while passing the screws, there's a possibility of you hitting the neural structures because of the fiddle factor, which all of us have. The next is after passing the screws, because everything is nicely covered. Now just do the ponte and put the rod. So you delayed the ponte as late as you can. So this exposure of neural tissue and bleeders, etc., is the least. The third, which is the optimum time. So what happens is once the screws are in, the screw heads tend to crowd and you don't get an opportunity to get into the facetal joint. And that becomes a very, very practical problem at the concave apex. So the concavity of the apex, you just can't get in. And hence doing this osteotomy that late is not so feasible. So my suggestion is that what we do is that at least at the concave apex, we drill holes for the screw, we put the owl in, we palpate, we are ready to pass the screw, but we don't pass the screw. We plug it with a ball of bone wax and then do the osteotomy. So it's the best of both worlds. You're ready to pass the screw, but the screw head is not sitting on your face. You get to do the ponte and then pass the screws and then correct. Okay, so you can practice whatever works for you. If you pass screw heads, you can distract and then do the osteotomy, but it's messy. Anything else, Arjun? You want to add anything here? Anyone else wants to add anything or ask any question? That table is quiet. Arjun.
Which cases do you do it and which cases do you avoid doing it?
So that's a loaded question. When would you not do a ponte osteotomy? I have very few contraindications to not do it, but I would think neuromuscular curves because a high incidence of pseudoarthrosis and they anyway floppy curves. So I would tend not to do it. Otherwise, I don't almost ever not do it. Arjun, you have any situations where you don't do it?
So the smaller AIS curves, do you feel it's required there?
Yeah. So the bang for buck. The question is bang for buck. So there's some very easy correctable curves where you can get away without doing a ponte. And what Dr. Dhawale is saying is that if you can not do it and still get a good correction, you have not gone into this risk of neural damage, bleeding, etc. But I still tend to do it in even smaller curves, even though the risk benefit ratio or the bang for buck is not favorable, because I want to get that bone and I want to get that fusion area rod up. But I think Dr. Arjun does not prefer to do it, and it's a legit, it's a legit argument. Anything else, Dr. Priyannk? Right.
Commonly, we do that. Sometimes we do that transverse posterior excision. Is a part of pontes or not?
Yeah, so that's the next step. So ponte will involve getting the yellow ligament down to both the facetal joints or half a facet joint if you wish. And then you move to the next release, which is rib release. Okay, now traditionally release is always done at the tether, right? However, when we do an anterior release for scoliosis, we do the convexity. Anyone thought about it? Why is a convexity release called a release in scoliosis? You get my question, right? When you do an anterior release, you're always doing it from the concave side. A release, whether it's a CTV or a flexed elbow, you do it at the concavity, right? You do it at the tether side. So actually, it's a misnomer. Doing anterior release is a misnomer. When you do an anterior release, you're actually doing a discectomy, creating room. You're not doing any release. The release is actually an axial release. You're trying to separate the bones out. It's not theoretically a release. A release would be this. When you go on the concavity of the of the curve and do a concave rib release and not a convex rib release. So when we do a costoplasty, it's not a release. What a costoplasty does is that it sits down. It's a release of the rib. The rib gets released and it can sit down, but the spine does not get released. So what you need to actually release is the concavity, and the concavity, the ribs are spider webbing in. The ribs are all pushing in, and it's quite it's quite challenging for us to do it because the pleura is sitting right there. However, that is the way to do it. So one of the ways is that instead of going into this costotransverse and costovertebral joint, you need to actually get both the joints off. This joint is easy to get out, the costotransverse joint, but the costovertebral joint lies very deep and it's bordered by the segmental artery. So the minute you do that, a bleeder pops out and there's a pleura blowing on your face there. So one of the easier ways is what Dr. Harshal mentioned, is just knock off the TP. So if you can dissociate the TP and then dissociate the rib, you get a floating fragment there without getting into the hair of that costotransverse joint, at this costovertebral joint. So this is one technique that most surgeons across the world are following. You take a bone chisel, an ultrasound bone chisel, cut down through the rib as deep as you can, because here there's a free space. Though it's a give way feeling, the space here does not belong to anything critical. And take this as down, as deep as you can, and then knock off the rib from the top. Of course, while doing this, you want to get the undersurface of the rib cleared and not hit some, important soft tissue. But this will create a floating fragment, and you can do multiple levels, and you'll see how the curve detethers by doing this. This should not be done in all cases, for sure, because there's no advantage of this procedure except release. So if you don't need the release, you don't want to visit the pleura. there's no fusion happening here. In fact, it's, you know, taking away some rib bed. There's no bone graft. You're not pulling that. You're just leaving that fragment there. So the other one should be done in many cases. This should be done in many cases, regardless of release. But this one should be left for the you know, more difficult or the tighter cases. Now, after this, you want to get your you know, anchors in, and the anchors will then realign the spine to the rod, or the rod will realign to the you know, to the anchors. The principles of anchors are as many anchors as possible is good. So there's something about, sorry, this pointer. Okay. So the principles of anchors are as many screws as you get is good. So again, there's a lot of discussion about what should be the implant density. So 100% density will give you the maximum correction. Full stop. Dobara mat puchna. There is no science in saying that I'll put less screws and get the same correction. There are many disadvantages of putting more screws, and the most important is cost, and the other is that you lose you know, area for bone grafting. But there's one covert disadvantage that in you know, in studies it's been found that higher screw density relates to hypokyphosis. And again, as you know, junior surgeons, we all feel that correcting scoliosis is all about getting the coronal plane right. But as senior surgeons, when you do, you will realize that it's really about getting the sagittal plane right also. All these girls come with a flat back, and they want that, they want their back to be rounded, the Cindy Crawford back, as we say. And we tend to miss that out. And that's where these cobalt chrome rods, etc., came in, right? So you tend to hypokyphose by putting more screws. Most of us tend to do 100% screw density because we know that 2-3 screw bahar jane wala hai. So that, you know, that sums it up. But a 70% screw density is acceptable, but more the screws, the better it is. So now you figure out what works for you in your practice, and you know, work around that. The other is, if you have to put selective, then you want to put them on the strategic vertebrae, and you all are going to tell me what are those strategic vertebrae in an ensuing talk after this. Try to work more on the stiff segment. So the apex, you want maximum screws. So the minimum you want is 4 screws on the top and 4 screws at the bottom. So if you've identified your upper and lower instrumented vertebra, you put 4 screws there, at least 3, but ideally 4. And then you want to get your maximum screws at the apex. After that, once you decide which correcting maneuver you're using, you use that side rod for more anchors. And then you can skip the side that you're using as a neutralizing rod and put less implants there. Though we will show this to you on the model, you have to learn to pass freehand pedicle screws. And all of you who have learned passing screws under Shyam guidance have to unlearn that if you want to do scoliosis surgery, because there is no way in the world that a Shyam will help you. And in fact, Shyam will confuse you. And of course, navigation is here, O-arms are here. You won't have them available everywhere. So my personal request is that you've got to learn the freehand technique. And, you know, to your advantage, it's been proven in sequential studies that freehand pedicle screws are actually safer than image-guided pedicle screws in deformed spines. Because you're getting a touch feel and you're not going by, you know, an eye and ear evaluation. You're getting a touch feel evaluation. And we'll try to show you these. And then the last bit about which screws to use. So anyone has any thoughts? Mono or poly? Which one would you use? Mono or poly?
Mostly polyaxial and
why not mono? Which will give a better correction?
mono.
So then why not mono? Anyone?
So rod can be manipulated as per in poly. So we would prefer poly.
Yeah. So both of you are right that mono gives a better correction because there's no movement between the screw and the bone. So once you put the anchor, you want the anchor to manipulate the bone. But if the anchor itself is floppy, that manipulation goes away. But there's a big problem that when you put a mono, it's all good to get the rod, to get the anchor to the rod. But when you look at the sagittal profile or when you look at the flatness, if the screw is even slightly off-centric with the rod, so if the rod is like this and the screw is, the axis of the screw is slightly off, then this kind of a adjustment tends to happen if you're forcing the rod in. And that creates either a shaving off of the shaft of the screw or a weak screw rod interface. So in the end, you're creating a weaker screw than a stronger screw, because the screw itself is strong, but the entire assembly gets weaker unless you've absolutely contoured the rod at every level, which is difficult to do. Your rod is contoured in a global fashion. So at some point, you will find that the screw on the lateral view is sitting on the different axis. A poly nicely falls into your alignment, but when you turn the rod, the poly head moves. So again, you missed a trick. So a uniaxial screw is what is actually the right one, where the screw moves. So again, if the patient is lying like this, head here, foot here, the screw will allow this movement, a cordocephalic movement, the screw head. So it will nicely sit on your rod. It will solve that problem that I just created with a mono, but it is blocked on the lateral movement, on the mediolateral movement. So when you do your derotation maneuvers, the screw behaves like a mono, but on a cordocephalic angle, it nicely sits on the rod. So that's the screw that you want to use. And of course, reduction screws are a big boon because they're long tap screws. They have a big head, so the rod is accepted much faster, and you don't have to shove the rod deep in to get get the rod in. You have to know how to use hooks and wires, and that's been a big problem with your generation, that you all have never used it. And again, struggle hard, scrap around and learn this technique, because you'll have to find someone who can teach you this, because it's not being used in daily practice. But even today at the topmost center, every fifth or sixth case, you'll see the surgeon falling back to a hook or a wire because a rescue is needed in a surgery. And just imagine if your top screw goes bad and you then need to go into the neck or something to put a screw. You'd rather put a wire and a hook and salvage your top screw, right? It's okay in between, you can let the screws go. But at the top and at the bottom, you can't skip or add a level just because you don't know how to pass a wire or a hook. So learn that technique. And finally, fusion, the best time to do a fusion. The fusion has to be done diligently. There's some thing about when you use burrs, you can actually get into the spaces better, but you can actually cause thermal damage. Osteotomes are, keep the bone alive and bleeding, but it's messy to get into the spaces. So again, the best time is at the end because you've got your correction right. And the problem is that the screw heads are going to cover the bone, the bone area. The source of graft today is the spinous processes and the facet joints, and we don't tend to use the PSIS, but that's always available to you just by extending your incision a bit. And with that, I think I'll invite Dr. Harshal to talk about about correction maneuvers while he's setting up. Any questions, or can I ask you questions? Any questions on what we discussed? Can I ask you, what do you think is the difference between a thoracic spondy and a lumbar spondy? Which is easier for you? So we can't answer. Anyone on this table?
Sure, I think lumbar ponte is much more easier than thoracic ponte. Due to the space available in the lumbar region and the thoracic region, there is a laxity of space.
Absolutely right. And there's a quad and there's a root. And you got ellipse all alike. So ellipse is actually a lumbar ponte. You got it. The lumbar spine, the space between the two laminates much wider. There's no spinal cord. And every day one ellipse in your practice. Ellipse is what you're doing in the body. Exactly that. Anything else?
Sir, in Ponte, where would you stop? Like, where would you end doing complete Ponte, and where would you stop just excising yellow ligament?
So, excising yellow ligament torsif is not Ponte. So, when you're not doing still excise the yellow ligament, but I think the next question is, when will you do a half Ponte or a full Ponte? What we discussed right now is normally I go for a full Ponte, but if it's bleeding at every level, no, so it gives you that sense. There's some bleeding patients with a lot of epidural congestion, some non-bleeding patients. So if I have, I don't have the ultrasound cutter and my first Ponte started to bleed, the second one started to bleed, I will then cut my losses and do half Pontes. Otherwise, I will commit to doing a full Ponte at every level. So an aggressive surgeon will do that, but it's not needed. It's not okay to just for bravado do a full Ponte and then have a 1 liter blood loss. So do what comforts you. Literature shows that half Ponte is reasonable. So the bang for buck in a half Ponte is all right. Okay.
Sir, I have a question for you. What we have discussed till now is the posterior release. So where does the anterior release stand now in today's day and age? When do you do anterior releases?
So again, a very relevant question. I'm glad you brought this to fore because we're almost never doing. So anterior release is actually a much better release because you're actually getting into the spine. You're getting the derotated spine in front of you, getting the entire disc out. The problem is that it adds another surgery. And if you think about it, scoliosis surgery is a cosmetic surgery. So you're already giving a young girl a scar at the back and now you're giving one under one breast. So we've almost all gone away from anterior releases. So the three places where I would think of doing an anterior surgery, whether it's a release or not, is a very rigid, more than 90-degree curve with less than 20-30-degree flexibility, which also I would think twice because we have got great posterior maneuvers now available. But that's one indication. The other is a growing child. If it's a growing child, you want to do an anterior surgery to do to do a fusion. Right. So the third then could be a lumbar spine because an anterior correction is far more effective with far fewer levels of fusion. Because when you do an anterior correction, though you'll have not seen too many, you will realize that you're working at the force nucleus of rotation. So the derotation achieved by an anterior scoliosis correction is head and shoulders above multiple pedicle screws at the back. Again, dubara mat puchna. Don't argue. Because it's when you see it, you will know. It just sits in, and scoliosis is a rotational deformity. The rotational deformity is the first, sagittal deformity is the second, and coronal, what we see and what we discuss, is actually the third deformity. It falls in line. So if you get the derotation right, you're going to get everything right. So in the lumbar spine, you can actually save 1 or even 2 levels if you do it anteriorly. But once again, it's an ugly scar right there. And our Indian girls who wear blouse and saris, it's like very, very non-cosmetic. But these are the 3 places where an anterior surgery still stands. Yes.
Sir, you said that anesthesia and giving anesthesia is one type of release. So what about in neuromonitoring will not give the muscle relaxant? Does it affect the release?
It does. Absolutely. Again, absolutely good question. So in the past, we used to not use neuromonitoring and we would get a fantastically open spine. And today, all cases have a neuromonitoring, and in neuromonitoring, you can't give muscle relaxant. And that's where we see that getting restricted, but the value of neuromonitoring is much higher. And we are doing so many good releases that we don't really care. But it's a good thought, yeah.
So one more thing, like to prevent PJK, what is the extent of release in the ends of the instrumentation and all? What should be the extent?
So again, it's a good question because in the past we used to think that PJK happens because of the damage we do at the top. Okay, when we pass a screw or when we do a release. Now that's partly true, but it's not really true in the thoracic spine. So in the lumbar spine, if I'm passing an L3 screw and I've damaged the L2-3 facet, I'm likely to get a PJK. That's relevant. But in the thoracic spine, the spine itself is very stable. There's a rib construct that works with the sternum. So what we've come to realize is that so in the past, what we used to do, on the top of our construct, we would pass a wire, interspinous wire, just to prevent PJK from happening. But that's now known to be bogus. PJK happens if you've stopped in the middle of a kyphosis, no matter what you do. So if you've cleared that kyphosis, you will not get a PJK. So you don't have to be so cagey about passing that superior screw. What happens is the superior screw, the topmost screw, the T4, T3, whatever, is a difficult screw. You're sweating when you're passing that screw. And the more anatomy delineation you get, the screw gets safer and easier to put. But in your head, you're thinking PJK. My suggestion is don't think PJK, because if you've got your level right, you can safely erase the facet and still not get a PJK because it's a stable area. You'd rather have a safe screw than worry about PJK. So it's again a good thought because I never thought of discussing that.
I would also like to invite our Zoom faculty also to come in. If you have any questions, we are able to hear you also.
Or suggestions.
Or any suggestions also.
Right, so, yeah.
Sir, how can we plan the sagittal profile correction by doing these ponties?
So actually, ponties helps doing a sagittal profile correction. The problem of sagittal profile correction is when you're worried about this coronal correction and pushing the rod in. You've seen how scoliosis surgeons sweating and pushing the rod in. You're actually flattening your rod contour. And that's the big problem. And Manabu Ito's paper has shown that there's a 30-40% change. So you contour the rod nicely and you're imagining that you're putting that rod in. But by the time the rod is in, if you chance to remove it again, you'll see that it's 30-40% flattened. So ponties actually prevents that because the spine is looser. Your decision about corrective maneuvers prevents if you use the right corrective maneuver, it will prevent a flat back. Using a cobalt chrome rod will prevent that. And nowadays, I forget the metal, there's a new rod that's also come up, which is a much stiffer rod. Stainless steel rod or a Harshal correction, you would never get a flat back. And finally, the last thing that Dr. Harshal will talk about is in situ bending. And we again tend to forget it because you've done all the procedure in 4 hours and your clinic is waiting. You tend to not do that, but always try to do an in situ bending after all your implants are in and you're ready to close, because that will give you a beautiful sagittal contour.
And one more thing is regarding the rib hump. In which cases we'll have to address that issue of rib
So
hump?
rib hump is again a controversial question, but the bottom line is that do not do costoplasty until you finish your correction, because 50% of the times you finish the correction and you think you don't need it. But pre-operatively, there's one way of evaluating is a shoot-through film. So you ask the patient to bend 90 degrees and do a shoot-through film, and you will see which part of the rib is most prominent. So if it is the rib alone, there's a good chance that you will get away, by not doing a costoplasty. But if it's a transverse process, I'm sorry, I stand corrected. If it's the transverse process, there's a good chance that derotation will push it down. But if the shape of the rib is bad, which means there's an apex of the rib sticking out, there's a high chance that post-op you're going to need to do a thoracoplasty. But in the end, you correct and then get a feel, because you do 2 ribs and then the 3rd and 4th stick out. Then you do 3rd and 4th and the 5th and 6th. It's a relative phenomenon. So you take a call. And there's one more thing called concave costoplasty, which many of you all may not have seen. And once you start doing the concave rib releases, if you leave enough stem of the rib intact and don't just cut it, don't make it short. If you keep a nice long rib intact on the concave side, after your rod is in, you can actually put that rib on top of the rod. So if you have 4 ribs that have been released on the concave side, you can actually swing them over. And if you put them on top of the rod, you actually get a filling up of the concavity while you're pushing the convexity. And that's again a procedure you got to think about, especially very badly deformed cases, where that big dip here is what's bothering the patient. It looks very good after that. You can tie it together. Thanks.
Dr. Nene, one more question. How often now in your practice you do convex costoplasty in AIS cases?
Less and less, obviously, because the better the corrective maneuvers, the better the instrumentation techniques. We're getting very good, very good correction of curves. So I think less and less. Thank you. I think you can take it.
So I'm going to talk about corrective maneuvers in scoliosis correction surgery, and I'm going to put up this slide again. Because it's very, very important and relevant that principles of AIS correction remains good preoperative planning, generous soft tissue and bony release, which you have already learnt about, and strong anchors in maximum vertebrae. What happens afterwards is appropriate corrective maneuvers. So you have to really plan your corrective maneuvers, and accordingly only you have to put your anchors, and then stable construct and fusion, which is the principle of our surgery. So corrective maneuvers in AIS surgery are typically in last 5 to 6 decades, they have steady progression in the corrective maneuvers, where initially it was described as distraction and compression maneuvers of Harrington system. And now when we have anchors and pedicle screws, which give you 3-dimensional correction possibilities, which has axial, sagittal and coronal corrections available. There are few correction maneuvers which we should know about. There's a global distraction, segmental compression distraction, translation, where we typically now do posteromedial translation, cantilever maneuver, global derotations, where differential rod rotation is a concept which we should know about, and DVR, that is direct vertebral rotation, and osteotomies. First maneuver which was described was distraction, and now when we hear about distraction, almost all the surgeons will say, no, I don't want to do a distraction. And there's a reason for that. Whenever we do distraction, it typically leads to a flat back. So distraction is a correction in one single plane. When you're pulling 2 ends apart, it will straighten the coronal as well as sagittal profile. And now we know when we do distraction and we flatten the back, we basically achieve good coronal correction. But more often than not, we spoil the sagittal balance. And we know that scoliosis surgery is typically a cosmetic surgery. Your aim is to achieve a good spinal balance. And when you lose all important sagittal balance, it has significant patient-related outcome and clinical outcome issues. But still, you should know about distraction, which we'll know about in a couple of slides. So if I give you this rod and I tell you to straighten it, what you'll do is you'll typically hold it together and pull it apart from the ends. But when I ask you to straighten this rod, what will you do? You will use some other methods. You will try to press it down in the center and you'll do rotations and compressions and everything. So typically when you have a curve which is more than 60 degree or any bend which is more than 60 degree and you try to correct it, the first few degrees happen with distraction. The correction happens with distraction, but beyond 60 degrees, the distraction won't really help. So this is the same principle in a spine. When you have more than around 100-degree curve and you say, I don't want to do distraction, I want to do some other maneuvers, but first a few degrees right up, suppose 100-degree curve, the first 30-40 degrees will happen with distraction. Even if you do rod translation or cantilever maneuver, and you will find that your spine is actually lengthening, your rod will become shortened. So you have to always remember that distraction is the first corrective maneuver. So similar in this case, we see that Harrington system was used to achieve correction. Now there are a couple of surgeries in which we do use distraction, like collapsing curves in neuromuscular scoliosis. Like in growth rods, the principle is distraction. And typically when we use vectors and extra spinal distractors in some of the cases of early onset scoliosis. There's one more thing which we should know about is the segmental compression distraction. Typically, it is the last corrective or setting which we do in the our corrections. And when you do at one level between two vertebrae, it is much safer and much easier to do distraction and compression. So like you see here, we are trying to achieve distraction compression. Typically, you do distraction on the concave side and segmental compressions on the convex side. The next maneuver you're talking about is rod translation. It is a coronal plane correction. Rod translation, what you are trying to achieve is you're trying to get the bent spine towards a straight rod. It is typically done on a concave side. What you want to do in this case, typically if you see, there's a rod translation happening at, this is a double major curve where you are using rod translation maneuver to correct two curves. And in the proximal thoracic curve, you are getting the spine towards the rod in one plane. So it's a dollar type of a correction. And in a lumbar spine, it is going on the other way. Translation using sublaminar wires. When you have a large curve, typically when the rod is staying far away from the curve, or from the apex, and it is very difficult for you to thread the rod into the screw, even if you are using the reduction screws. And that time the sublaminar wires really help, because sublaminar wires are like a longer reduction screw, and you can thread these sublaminar wires and try getting the rod or the spine towards the rod. As in this case, you can see that sublaminar wires have really helped us to get a good amount of spinal balance. Again, in this case, with a neuromuscular scolia and collapsing curve, we have gotten a good amount of correction with sublaminar wires. Yeah, so you typically want to start from the ends and go near the apex so that you can have less stress on the wires. Concave first and then convex again. Any comments, sir?
What does the convex do then?
So typically convex wires are neutralization wires which try to
it also helps push the rod down.
So
when you actually tighten, so I'm just going to take a minute. When you tighten, because none of you all use it and I have used it. On the concave side, you tighten the wires like this towards the rod, because you're pulling the spine towards the rod. On the convex side, you tighten them vertically down because you're pushing the rod down onto the curve. So the convex rod actually serves as a convex cantilever rod. It pushes the rib hump down. You don't want to miss that opportunity and just use it like a neutralization rod. So invariably you use this with a rectangle, and after contouring the rectangle in the perfect manner, it's stainless steel 6 mm, so much, much stronger than the rods that we use. You latch on at the both ends, like Dr. Harshal said. So you latch the the rectangle, and the curve is sitting out of this rectangle. And we have a video here for you all to see during Khana Pina. So you'll get it's a step-by-step video of how to do a scoliosis correction using a spinal loop rectangle. So once you have the 4 or 5 wires on either end, you start correcting the concave side centripetally from distal to proximal. From the ends to the center, with an assistant giving a corrective 3-point push on the spine, because the wires, unlike the screws, are not rigid or snobbish. They are pliable, so they need some assistance. Once put in place, they will hold on. But their ability to correct is a distributed force rather than a screw or a reduction device, which is a one-time force. I hope you're understanding. So you have to coax it in, and then on the convex side, you push the rod in again from in the centripetal manner, and you get a beautiful derotation correction, because the wire actually is not sublaminar anymore. It's subpars. It goes on the side. If you think about it, when you put a wire on a straight spine, it's a sublaminar wire. But when you put it on the side, it's actually drawing the spine, the vertebra in that manner, not just this manner, because it's latched on there and not here, because the vertebra is like this. So when you tighten it, this tends to happen. And it gives a significant derotation, which we've proven on post-op CT scans. So it's actually a beautiful technique. It's just that it's not industry friendly. It's $20 a wire. So it's been, thrown out of the market. There's been, we actually presented at the SRS, which is the world's biggest forum of deformity surgery. 4,000 wires, and I have presented it in 2002 or 2003, an experience of 4,000 sublaminar wires with zero neurological deficit. And all of them are documented. So even this thing about neurology is unfounded, and the technique is actually very simple. It's just that it's a lost art, and there's no point sitting and saying, "Hamare time mein aise karte the." So we'll just move forward. But at some point, you all should all be aware of how wires are passed, because it will help you somewhere or the other. Right? Thank you.
So basically, there are now certain screws available in the market, which basically tilt so much that they can, the top loading screw becomes a side loading screw, and it is easier to do rod translation. Previously used to have the USS1 and USS2 system, which was side loading system, but now they have stopped manufacturing them. This is a small video of that same. So if you see, the screws can have almost up to 60 degrees of rotation available, and the top loading screw has become a side loading one, and the rod translation, rod placement becomes quite easier, and then you can achieve your correction by rod translation and rotations as planned. And as you can see, they're sequentially tightening, so there's no stress on one single screw. They're sequentially tightening all the set screws on the top. The downside of translation maneuver, why not everybody is using translation? Because there's a lot of pull on the implant, and implant can give away at the implant bone interface. You have to have more anchors, typically on the concave side, and spine has to be supple. You have to do more releases. The translation maneuver works best when you have a supple spine. The next maneuver you're talking about is cantilever maneuver, where you are basically trying to bring the straight rod towards the bent spine. So it is typically done on the convex side. What you do is you anchor the rod on the spine and on the convex side, and you try to bring that rod towards the spine. And by doing that, you try to achieve a cantilever maneuver and correction of the deformity. It is largely a uniplanar correction, and you should know what are the advantages of cantilever maneuver, because you can push the anchors. Here there's no stress on the implant bone interface. You need fewer anchors for that matter, and it is good for rigid and less rotated curves, because it's largely a uniplanar correction. Upper thoracic curves where you don't need a lot of rotation, or sometimes the rotation, achieving rotation is quite difficult. The cantilever maneuver can really help you out there. There's something called as concave cantilever also, where you can put a rod on the concave side, straight rod, and try to correct the deformity. The biomechanics are totally different, and you should be quite aware of, while doing all these maneuvers, you should keep a watch on your neuro monitoring and MEPs.
So, Dr. Harshal, can you tell us what can go wrong in this one?
So basically, when you are doing a concave cantilever, your screws can plow in medially
Yeah.
and can cause an issue. So your anchor should be quite strong. And
So the screws plowing in
screws
is a
can
problem.
medially.
Also, do you have any thoughts on what rod material to use for which maneuver?
So typically, you want to have for cantilever all these maneuvers, translation as well as cantilever. What you do is your spine gets the shape of your rod. So you have to have a very stiff and good rod. So COCR rods typically we use for both translation and so cantilever also, sir.
So the thought is that when you're doing a concave correction, you try to use a softer rod because it's pulling on the implant.
Yes.
So if the rod is snobbish, the implant will give way. I mean, the anchor will give way.
Yeah.
While a pushing maneuver, which is like a cantilever, you can just be bindas and just put a hard rod, which will not, which will not. Arjun, what do you think? What is your thought process on implant material? I hope everyone sync with the discussion. What is very rigid, the corrective potential is very high, but the implants can give way, the anchors can give way. But if the rod is soft, it finds a middle path and allows, accepts and adapts. And the failure happens at the rod level and not at the implant level.
So if like just what Sir said, so if you are worried about, the bone quality, so if it's a very young child or, if it's a very older patient, or you feel that there is osteopenia, then you're better off using a less rigid material.
Yes.
And if you feel that you have a good anchor density and you feel that the screw bone interface is not going to fail, then you're sort of good to use a rigid implant,
Stiffer.
like cobalt chrome. But it's all about understanding what's going to happen. And sometimes, even with experience, you'll have a failure of the screws. But it's about that assessment of what you're getting, and of course, having enough to correct. So I mean, I think it's something that we're still trying to figure out, but you need to understand that as you do it. But titanium is sort of a more flexible, less rigid. So, less chance of an implant failure, but obviously you're going to get a lesser correction. Cobalt chrome, you'll get a better correction, but yes, bigger chance of a failure of the screws. So yeah, I mean, you got to titrate everything, I think.
I have another question for the house actually.
Yeah.
Why do you, one of you, maybe Gajen, you can tell us, why do you think world over, even the top centers use sublaminar wires for neuromuscular scoliosis? The answer to this question has a lot of biomechanical thinking. That's why. All over the world, even in Nottingham, Queens, they'll use a sublaminar wire construct for a neuromuscular scoliosis and not rods.
It's very rigid.
Very rigid, yes. And it's a floppy spine. So you want a
floppy.
really rigid construct because the spine is not going to be doing its own thing. It's going to, what else? Rigid because it's stainless steel typically. There are many more important reasons. So bone quality, what Dr. Arjun said, that in neuromuscular, bone quality is really flimsy. And in the sublaminar wire correction, there's a very even distribution of the forces. So one screw pulling out will not happen. It's a gradual coaxing that happens. So the chance of anything cutting out is much less. What else? Profile. The profile is much, much lower than a screw head. And neuromuscular scoliosis have a very poor soft tissue cover.
Medicals and that are very.
And soft tissue cover. The soft tissue cover is poor. So you want a lower profile system, which the sublaminar wires tend to afford. Anything else? Multi-level construct, like screws, typically we don't pass at every level, but wires you have to pass at every level. So it's 100% density. Each level is harnessed by 2 doubled wires, which is like a 4 times stronger. So I think these are the reasons. So there's a biomechanical, yeah.
With wires cutting out, so because they just come out of the canal, and the chance of damaging the cord is very less, even if the implant fails afterwards.
Now we are going to talk about double rod cantilever. So double rod cantilever gives you large or huge amount of corrective force, which is typically required for rigid scoliosis. But you should be aware that it is at the expense of, it is associated with some neurological injuries also. So you have to be very careful while doing that maneuver. And typically double rod maneuver, you use both convex and concave cantilever maneuvers, where you thread both the rods and try to correct the spine and try to bringing the straight rod towards the bent spine. This is an example of this is a video of a cantilever mechanism where you're threading the straight rod to a bent spine, and then you are trying to bring the rod towards the spine, achieving the correction. So there's a couple of technical tips while using the reduction maneuvers. One of them is if you are using a translation maneuver and when you're using a cantilever maneuver, the placement of your screws. So reduction screw should be at the apex on the concave side for the translation maneuver. And when you're using your primary maneuver of correction is going to be cantilever maneuver, your lower screws, the end screws should be the reduction screws to have less stress on the implant. Again, we're talking about the translation maneuver. What typically you should again remember is that, as I told earlier, that whatever is your rod contouring is going to be there, that is the shape which spine is going to take. So when you're doing translation maneuver also, you should have a good sagittally contoured rod. You keep it straight, coronally should be neutral, and then try to make sure that your assistant is holding the rod straight, and then you're trying to do a translation. That's the posteromedial translation which we are doing nowadays. Coming to rod rotation maneuver. So Cottrell and Debussy had this idea of basically rod rotation. And if you see your actually how the spine looks in a coronal plane, you're having a coronal plane deformity. And if you just turn it and see in a sagittal plane, that is the actual the contouring you want for or that's the balance what you want for the sagittal plane. So that coronal plane deformity, if it goes into sagittal plane, you will have a proper sagittal balance. So rod rotation really takes care of that when you convert a coronal curve into a sagittal curve. So you are trying to achieve that coronal curve into the thoracic kyphosis and a lumbar lordosis. So it's like a bucket handle. You're trying to turn it so that you can get a proper sagittal balance. In rod rotation maneuver, your concave rod is a workhorse rod. So you try to thread a rod and try to do a corrective maneuver from convex to concave, and that leads to a thoracic kyphosis. It actually gets your vertebra in this fashion so that the axial correction also happens and you get a thoracic kyphosis and a lumbar lordosis if whenever required. In a global derotation maneuver, you basically thread the rod as in a coronal plane. You don't really need to do any translations or anything. You just you properly contour the rod to your coronal plane deformity and just try to get it into the sagittal plane. So this is what you exactly try to do and get it neutral in your coronal plane. So automatically the deformity tries to correct. So this is an example where you are basically having a dual rod. Basically, whenever you are having anybody wants to tell me how is your contouring for the concave rod different from the convex rod? Tejasvi? Difference between a concave rod and a convex rod contouring? Hriday?
Concave rod and under contour the convex rod, because since we are using the concave rod as the basic rod rotation maneuver, so that we get the sagittal profile, a more kyphotic back in a flatter back patients.
Correct. So your concave rod is typically your correcting rod, and you want to achieve a good thoracic kyphosis. So you want to get those, and you want to have a rotational correction also. So you want to get that hyper contoured rod to get the proper correction. So if you see here in this video, you can see there are two types of rods which are there. Whenever you want to achieve kyphosis correction, you should have a large distance between your apex, kyphotic apex and the rod. And when you want to have a scoliotic correction, you want to have sorry, the video is not properly playing. Yeah, you want to have rod at a different height so that when you are trying to thread the rod, the axial rotation happens. So as you can see here, low height and high rod difference, and it whenever you are threading the rod, it rotates. In a global rod derotation, basically what you're doing is there's a chain of mobile bones and you're realigning by the end-to-end force. Sometimes the middle ones of the spine may give away. And the other issue is that it can rotate on, basically when you're trying to, what you're believing is that rod rotation, the movement will happen in the same plane, but sometimes it can just rotate on the axis and deformity can worsen. That's the derotation which can happen. And that is what you want to prevent. And there are a couple of, so basically you can see, if you can imagine a 3D thing, that where you're trying to do a rod rotation, you're trying to correct the rotation or the tilt of the vertebra, but suddenly the tilt can go in the other way around, and that axial rotation can worsen the deformity on the convex side. So what you should do to prevent that is you should push on the rib hump, or you can actually use towers to push it down and coax the spine to go the other way and achieve the correction. Other technical tips for derotation maneuvers are that you should use it in more supple spines and control the apex while you're trying to derotate. And more anchors are required on a concave side. So again, here we can see that there's a differential rod rotation, that a concave rod is a more contoured rod and a convex rod is a flatter rod, because it's going to be a neutralization rod. When we're talking about double rod rotation for lumbar curves are typically associated with significant rotation because there's no rib to prevent the rotation, and they can be significantly rotated curves. So here, to achieve a good amount of axial correction, you can use rods on the both sides, concave and convex, and try to correct it. And you should always give a second and third pass for two reasons, because there's a viscoelastic property of the spine. When you try to do first correction, tighten the knees, again hold it properly, loosen the knees, and again get the correction. So you can achieve more correction in a double rod rotation for lumbar curves. In this case, you can find out the significant amount of correction happening with a lumbar curve. And when you are having double major curves, so double major curves, basically when you're trying to do a global derotation, your concave rod on the thoracic is your correcting rod, and a convex rod in your lumbar is actually your correcting rod, because you want to achieve a lumbar lordosis. You want to do a hypokyphosis. So that's the way a single rod rerotation can help you for act as a correcting rod, and the other side works as a neutralization rod. If you're having a significant amount of lumbar rotation, you can actually use two rods to achieve correction of the lumbar lordosis first, then disengage one rod and use a longer rod to achieve a proper thoracic as well as lumbar corrections. So in this case, in a case of neuromuscular scoliosis, we actually gone anteriorly and done a correction and fixation, and then we came back posteriorly with help of distraction, translation, and rotation. We corrected. And coming back to the maneuver of direct vertebral rotation or a segmental derotation, basically, as we know, scoliosis is a three-dimensional deformity, and apex is significantly rotated, and that gives rise to that actually starts the cascade of scoliosis deformity. So and with the advent of pedicle screw systems, we have a good control of over the rotations. So what we do in DVR is basically put two pedicle screws in a vertebra, we hold them together and try to correct the vertebral rotation by force, but directly. While doing this, you should always remember that you are holding your neutral vertebra in its plane. So you don't want a neutral vertebra to rotate. So you ask your assistant to hold the neutral vertebra. You start from the vertebra adjacent to the neutral vertebra and try to correct rotations at each level and go towards the apex. So, and while doing that, sometimes you can accentuate the rib hump. So you have to again push the rib hump down. Poly screws typically give less amount of correction, as we have discussed earlier, and direct vertebral rotation can, so that's why if possible, we can use mono or uni screw. Any comments, sir?
No, I have a question. Clearly, the stress on the anchor will be very high when you're doing this.
Yeah.
Is there any way to negate that or minimize that?
So again, mono screws or poly screws really help. And apart from that, whenever you are trying, you basically hold the neutral vertebra in its place and try to achieve small corrections. Again, come back, again do small corrections.
What about block derotations? I was actually trying to ask you
So
that. Like,
block derotation is the next step where we actually put multiple towers and connect those towers and in toto try to derotate, and that really helps. So that prevents stress on a single vertebra, and it transmits the stress on the other a complete segment of a scoliotic segment. So this video is not actually working, but I would and in situ bending. So this is a last step which we typically do because we have done a good amount of correction. We have tried good releases, all the maneuvers, try to get a good balanced spine. But in the end, when we see because of either pliability of the rod or the maneuvers, you don't really look into the sagittal profile, and you can lead to a flat back. So at the end of a surgery, to achieve a good sagittal balance, because it's a three-dimensional deformity, and sagittal balance, as we all know, is very important, and it has a significant, as I told you earlier, that's a outcome is clinical as well as patient reported outcomes are significantly dependent on the sagittal profile. We do in situ bending with all those F benders and try to correct your lumbar lordosis and to correct your thoracic kyphosis in lumbar lordosis with the help of F bender at the end. And so always remember, these corrective maneuvers in AS surgeries is not as you can't correct the spine with a single maneuver. It's all combination of multiple maneuvers, either by planning or in a way, all these maneuvers really work together to achieve a good amount of correction. Any questions?
Arjun, your comments on which maneuver you use when?
So I think you can do almost everything with a rod derotation. Actually, you can do almost everything with it. And even if you have less implants, you don't have everything available with the rod derotation, you can easily do it. There are a couple of important things. One is, if it's a lumbar curve, then you have to always put the convex rod in first. If it's a lumbar curve, because basically it's not only about your coronal correction, it's about your sagittal profile. So when you if you try to do a lumbar curve with a concave rod and you distract it, you'll create a flat back. So you have to create lordosis in the lumbar spine. Basically, the failure of the Harrington was everything was based on distraction, and so you created flat backs. And really, in spite of everything that we're doing, the sort of real evolution was the CD system was you could sort of compress, and versus only distract. And that's what eventually we are still building on. Whether it's a hook you use or a screw you use, it is that ability, to sort of maneuver things. But that is the one additional thing I'll say. Otherwise, I think he's covered it very well. Thank you.
And you'll get a real feel of it once Spineway is very kindly, Samir, thank you, has given us bent models. So you'll get a real feel of the maneuvers once you have hands-on the model. Because it's slightly difficult to imagine, when he said concave rod and convex rod in the lumbar. When you actually see it, you'll know what it is. And we'll save all those questions for that time because it's more relevant then.
And very kyphotic, go for the cantilever, basically. I mean, simply if I have to kind of.
So can we like summarize which kind of curves, how you would go step by step? Because there are so many different maneuvers that we know. We know about cantilever, double rod rotation, double cantilever, translation, DVR. So is there something that you follow step by step to get a adequate correction? And which kind of curve you would follow what steps?
So very severe curve, you need to do DVR also, you need to do cantilever also, you need to do everything. Then you need to do more things. And segmental correction, but maybe it's a good idea to do it with the cases. So when the cases are up, maybe Dr. Nene can kind of put
it up. Let's involve. Which curve do you think you will use for a rod derotation? Like just the attributes of the curve as a global derotation, which is the typical curve. You can just think and answer. There may not be a set answer in your head, but now that you heard the lecture,
Main thoracic curve.
Okay. So not a double curve. A double curve can get a bit,
Yes, sir.
because you don't know which one goes where. A single curve. What else? How about the rigidity of the curve? So very rigid curve won't really fall in line with a rod derotation sometimes.
Yes, sir.
Anything else? A very rotated curve. If the bone is apex is very rotated, but the rod derotation, neuromuscular, very good. In a neuromuscular curve, the rotation is very, very less.
Yes, sir.
So again, a rod derotation is not what you want. You want more like a translation maneuver. Fine.
And sir, I want to ask one question.
Yeah,
What
yeah.
are the downsides of using sublaminar wire?
So the two downsides of using sublaminar wire is one is that it's intrusive in the canal. So typically all our this thing is extra canal, right? Scoliosis surgery. You're getting into the canal. The other is technique, because everyone's not learned the technique. You tend to do it by poor technique, where the chance of neurological injury becomes higher. These are only two disadvantages. Of course, the third is that it's stainless steel. The titanium cables which are used nowadays are not. They don't have the right principle of correction. Though they are MRI friendly and we use it, they have a very poor knotting property, and they don't have a implant memory. So the wire has to have a very good knotting property and a good memory. It can't unwind after you turn, because it's a sequential, graded turning where the thing is giving way. So titanium cables are not that good. Muslin tapes are not that good. You need a stainless steel cold cured wire, and they are MRI unfriendly.
Thank you, sir.
One other relative disadvantage is blood loss, because when you're doing wiring, you're going into the epidural space and you can have epidural blood loss. So you should have a good assistant, and you should know how to use gel foams and flow seals and all to minimize that blood loss, because these are small kids. So blood loss is something that you need to keep a watch on.
So where would you use a translation maneuver? In which typical curve? Would you use it in a curve with a lot of kyphosis?
Less than 60-degree kyphosis.
No, most scoliosis are lordoscoliosis. If it's a kyphoscoliosis, do you think a translation will work? I'm trying to coax an answer out of you.
Not really.
In a kyphotic curve, it's hard to get a translation. If it's a lordotic curve, the translation will pull it towards you. So in a kyphotic curve, you probably won't. What else? Where else? If your implant hold is not so good, if you have really thin pedicles, do you think a translation is a good idea?
It won't.
Because you're pulling against the implant. If the implant is going to give way, you flop it. If you've not had enough anchorage, also, if you're a young surgeon, you've not had all your screws in, you immediately switch to the convex side, right? So, and rigid. If it's a rigid curve, once again, the chance of it failing is much higher. So in a supple curve, you'd like to use a translation maneuver. What about a cantilever maneuver? Classic case for cantilever maneuver. Everything that I said here applies.
A single-sided curve, like
Okay, single, but then yeah,
lumbar
you can't be that choosy. Everything you can't apply to a single. So actually, you can use it for a double curve also, a cantilever, because you're literally pushing forcing the rod onto the spine, right? So the spine has to fall in place. So when it's a rigid curve, when it's a kyphotic spine, when your implant hold is not that good, all the stuff that you can't use a translation for, you can use a cantilever for. Getting it? Or am I just answering and you all are not understanding? Understanding, otherwise just ask, okay? Yeah. Double rod derotation, when would you use?
Sir, if it's a double major curve.
Double major?
Yeah.
I would not agree, because double major is two equal curves.
Yes,
A double rod derotation, you'll have to contour the rod quite differentially
yes,
to get a double major curve, right? Because as you heard from Dr. Dhawale, the lumbar curve, the derotation has to first happen on the convexity.
Yeah.
While the thoracic curve, you have to derotate at the concavity. So in fact, a double major curve will be struggling with a double rod derotation. Double rod derotation, put both the rods and derotate both the rods. That's what I meant.
Sir, if it's severely rigid.
Okay. Severely rotated. Severely rotated. So that's typically a lumbar curve.
Lumbar.
Because the downside of a double rod derotation is that it's a very powerful maneuver, because you're using two rods, like two muscle men are trying to bundle in you. So it's good for a spine that's going to give, which is a lumbar spine. Lumbar spine, they have the rib holding together. If you try to use it in the thoracic spine, something else will give way, because the corrective maneuver is so strong that something will give way. Got it, no?
Yes. Sir, I had a question.
Yeah.
if we are using a hook, how does it impact the rotation that we do? And
Yeah.
where would you prefer a
Yeah.
hook instead
So
of a
for this question, you need to know the biomechanics of implants. And you want to answer that? We've got a senior delegate here with fancy hair.
Sorry, the question is?
How does a hook impact your correction? Like, what's the downside of using a hook?
So again, as sir said, epidural hooks, and we have to put in epidural space, the chances of blood loss is much
I
more.
can put a transverse process hook,
Okay.
facet hook.
Yeah, and hooks have potential to cause the neurodeficit. Sometimes it can affect the nerves and the cord also. Again, hooks as such don't have the rotational ability, which can rotate the cord and correct it more as
Correct,
per the
correct.
pedicular screws. That's one of the drawbacks of the hooks.
Yeah. So to answer the question, hooks are great for a pull out. They have a much better pull out strength than a screw because it's an extracortical implant. And hopefully, if they're getting the hooks, we'll be able to show you what are the types of hooks that can be used. They have a very poor, they are not rigid, so they don't have a rotational, derotational ability.
3D correction of the curve is not possible with the hooks, which
Absolutely.
is absolutely possible with the pedicle screws.
Correct. Thank you. So hooks are good when there's a pull-out problem happening, which means that the curve is falling deep on the top. You protect the screw with a hook to enhance the pull-out of the screw. The other thing, next best thing it can do is a segmental compression distraction. Segmental. Okay, so they have their next best stability after their pull-out is their axial stability. And their worst stability is derotation. So if you want to use it for derotation, you're probably missing a trick. But today, sometimes you have to use a salvage hook even for everything. So that's when we use what is called a claw construct. So instead of putting one hook and leaving it, you put two hooks and press them onto the, so they try to become a rigid implant rather than a implant that's dependent on soft tissue tension. You should know how to use a claw construct, but then if you think about it, the best claw construct in the world is a sublaminar wire. A hook is either a whatever, 1/4 of a circle or a half of a circle, or at best 2/3, but a wire is a full circle. So wire gives you a complete hold, and so it's a much better way of doing a claw construct, but you don't know how to do it, so you don't do it. Thanks.
Thank you.
Any other questions or any discussion points?
What about DVR? Would you do DVR in all cases?
So it will be depending on how much correction that we get after doing the other maneuvers. If there is rotation that is there at the end, and if you want to significantly correct it, then we can try in all the cases. But if most of the rotation component we have corrected with other maneuvers, then we may not need it.
What's your take on DVR?
Basically, the principle is to achieve a good spinal balance, and if you with the AIS case in your I think DVR is not required in each and every case, but nowadays with towers and with the assembly which we have, we try to be greedy and we try to achieve a 0-degree curve. But
basically, there's no good reason not to do a DVR. Just like there's no good reason to not to do a good release. The more you do, the better it is, and there's nothing, because your entire construct is secured before you do the DVR. So the chance of giving way, etc., which can happen in all the other maneuvers, is the least. So there's no good reason not to do a DVR. Honestly, there's no good reason not to do a in situ bending either. But it's just that sometimes you're tired and you feel you've achieved enough and you tend to not do it, which is okay. I'm not saying all of you should do it in all cases, but there's no good reason. Arjun, do you have a difference of opinion? When would you not do a DVR? Arjun's actually a voice of reason. Okay, we guys, I'm slightly more on the other side of the spectrum. I'm ultra aggressive, and Arjun is the voice of reason.
So I think it's actually just about balancing the spine. So if you need to do it, you do it. If you don't really need to do it, you don't need to do it. I mean, it depends on the case. I don't think there's like a fit formula for every case. It just depends. I don't do something, say, in every case, or I would not say I would not do it ever. It just depends on the case, I think.
So basically you put the rod either by global derotation or cantilever, and eventually you use all these techniques for finesse. So DVR, compression distraction, and in situ bending. These are techniques that you use for getting that final finesse to get rotational correction and everything. So eventually, when you do more and more cases, you yourself will get a hang of the technique which works best in your hand. So having said that, I think we can
Sir,
move with the case.
actually, one point which I have not touched upon, and I want this because it's not a agenda of your today's talk, but it is important for this discussion that you use all these corrective maneuvers and you have neuro monitoring available there, and loss of MAPs and loss of SSAPs sometimes happen. So just briefly touch upon that. How do you manage that?
Drop in potential.
Drop in potential.
So maybe Arjun
Arjun,
can take
sir,
that
would be-
question. Arjun is a safer surgeon.
No, so basically, so first and foremost, I mean, so no scoliosis surgery in today's days should be done without neuromonitoring. In all cases, we do it with neuromonitoring. I don't think today it is standard of care to do these cases without. And any of our fellows will sort of vouch for how alerts are picked up and how you can prevent a neurology. And really, see, the goal of surgery is to get the patient, safely through and walking out of the hospital. Okay, you don't want a straight spine and a neurological deficit. There is no purpose to the surgery otherwise. And if you ask me, it is the single greatest advance in scoliosis surgery is the neuromonitoring. It's not the pedicle screws or the sublaminar wires or the hooks. It's actually that which determines safety. So if you're doing a surgery and you have the neuromonitoring available, it is your duty to respect what is being told to you by the neurophysiologist. So you can't sort of do the surgery without ignoring what they're telling you. So you have to then temper your surgery based on what's happening. It's very important that you also counsel the patient for a wake-up test, because if you have a true alert, you can actually try to do a wake-up during the surgery. And usually we are doing a multimodality. So that's a SSCP. SSCP is a somatosensory evoked potential where there is a time lag. And the motor evoked potential is actually which will pick up a real-time problem, where you're actually checking the muscle to see if there's a problem after cortical stimulation. Now the MEP alert, it will tell you. So suppose you put a screw and you misplace the screw, you're going to understand right there that there's a problem. So that the MEP is based on how many times you check it. You have to understand that anesthesia, etc., also affects everything. And what drugs you're giving. You can't give relaxants. Now, if you actually have an alert, the first thing you have to understand is it anesthesia related or is it surgical related? A good surgeon would always think that, okay, is there any surgical step I've done that has caused this versus just pushing it on to the anesthesiologist. Usually if you have a global problem, as in a loss of MEPs in the upper limbs and the lower limbs, it's more likely to be anesthesia related. But if you have a focal drop, say only in the lower limbs, then you have to obviously think that this is something related to what I am doing during the surgery. In which case, the first thing you could do is check and reverse that thing what you have done, whatever it is. Whether you put a screw in at that point, check that the blood pressures are good, check that the anesthetist has not given anything new, check that the BIS, if you are able to monitor the BIS, that everything is okay, and then sequentially get the pressures up. See that the temperatures in the OT are not it's not like too cold in the theater, so get the temperatures up a little bit. You can put some warm saline, etc., and give it some time. Many times if you've not had an issue, you'll understand, and usually the surgeon will know, within his heart he'll know if there's a problem that has happened with some maneuver, whether it is a screw placement or a while cannulating, or whether it's during the correction. And if you kind of take note and change it at that particular moment, you may be able to save it will remain an alert and not permanent neurology. And I have seen this many times. It's all depending on what you're assessing and what steps are taken. And it's a team, actually. It's you, who's working with you, the anesthesiologist and the neurophysiological team. And it can all be managed in a sort of correct way if you are able to take all the steps. But I'll ask Dr. Nene to kind of summarize anything that he feels.
Basically, it's the Spider-Man quote. Spider-Man said that with power comes responsibility. And as our power of correcting increases, remember you're manipulating the spine more and more and more because you've got powerful implants, great technique, great experience. So you're also manipulating the neural structures, and the threat to the neurology goes up. So if you see over the years, the incidence of neurological deficit has plateaued in the last 2 decades. It has not dropped down. Ideally, we are getting better at it, so we should get a less and less complication rate. But our correctability has gone higher, and with that commensurate, the rate of neurology has remained. It should have actually dropped down. Most surgeries are getting safer, but because we are getting more and more aggressive and because of the power we've got, the rate of neurological deficit remains the same. So you've got to really watch your ass when you're doing these cases, because it can really, Just recently we had the first screw we put in. I mean, between us, we must have done so many cases, right? Between me and Arjun at Padia. And the first screw we put in and we got a neuro alert. And the neuro alert specifically said, and I said, look, I have put this screw. I have put millions of screws before. I mean, who's going to say that my screw is bad? But the fact was that upper limbs were normal and lower limbs were normal a minute before that screw went. So we just have to suck it up, put your head down, swallow your ego, remove that screw. Again, I felt the screw and I said that it looks normal, it feels normal. You know, why is this guy? And I immediately said, this guy has a problem. The neuro guy, he does not know his business. But after I removed the screw, in 15 minutes, the MEP came back. So there's a lesson in every case that you do. And the most important lesson is that you got to be humble and, you know, coax the spine and not fight with the spine. I think that's something that you will hear again and again from scoliosis surgeons. It's big game hunting. It is not time pass disc and TLIF and MIS and stuff. It is like big game hunting. You get into the picture only if you have a big heart and a big heart with a small ego, right? So as far as the the techniques which Dr. Harshal very elegantly explained are concerned, you will a lot of questions must have come up in your head, and we'll try to address that on the hands-on because the whole crux of the matter is there. But we just felt that so save your questions, hold them in, and ask us when we are doing the hands-on. Try to clear every doubt because you may not get another opportunity like this for a systematic approach to this. So we felt that we should not do level planning, but you can't not do level planning at all. And to do level planning, you need to know the basics, right? So I'm just going to spend the next 15 minutes checking if you all know what are all the names, and I'm going to maybe get our newest recruit Manoj. You think this is an AIS? Just you keep using the mics and.
Yes, sir.
So why is this an AIS?
Sir, there is no. There are no features of any congenital
no
scoliosis.
Congenital features. Okay.
Features, sir. And, the patient looks more to be an adolescent.
Okay. Patient looks adolescent.
Yes, sir.
No features of congenital.
And
anyone has to challenge that? Is this normal? So this is possibly a congenitally fused. You can see two pedicles and one bone, right? One pedicle, one pedicle.
Yes, sir.
Okay, so keep your eyes open. I'm not homing in. I'm just arguing with you. The whole thing is going to be about arguments.
Yes.
Because there's no true and no false. Anyone else has anything else to add here? Do you think it's congenital? I mean, do you think it's AIS? Yes. Does anyone think it's not AIS? You all don't need to stand. You can sit and answer. It's it's a casual discussion. Does anyone think it's not AIS? Yes.
So the ribs look penciling of the ribs are present.
Penciling of the ribs. Can you point out?
Yes, sir. Lower ribs on the right side.
This?
Yes, sir.
Does someone feel this is a penciling rib or it's a floating rib? So penciling should really be seen in the non-floating ribs. Then you are calling it penciling. Floating ribs are often pencil. So argument invalid. Anyone else arguing for non? You can take my. How do you know the side now? Tell me. But what is this big bag here?
Heart.
Where should the heart be? So it's too funny to have a dextrocardia and opposite soul. So anything else? There's one very obvious thing glaring at your face, and you do not deserve a coffee if you don't see that. That this is not an AIS. Subhanshu. How many kids are born with wires in their sternum? Yeah. If the kid has had a sternal or an open heart surgery, obviously there's been a congenital heart issue with the kid, and obviously this is not an AIS. Period. AIS should not have any other anomaly. I'm saying this because the minute you have a suspicion of non-AIS, your entire thinking changes. It's a different animal. All that you're learning today just goes out of the window. You've got to think differently, because if you use the same rules for a non-AIS, you're going to muck it up. Because a non-AIS is a very unfriendly curve. And AIS, on the other hand, is a very friendly curve. So if you soft pedal an AIS, you're missing getting a great correction. These kids deserve a good correction. And if you're doing a non-AIS as an AIS, you're probably going to manhandle the cord. Am I getting across clearly? So that was the first. Now maybe the last table. Yeah, Tejas. I want you to point out. So I'm just going to run through, the X-rays, and then I want to ask you, "Ye pude, Tejas,
Yes.
how does this move forward?" Yes. Huh? Okay. So this is the AP X-ray. This is the lateral X-ray for whoever wants to see. We'll come back to the bending X-rays. Now I want you to point out the upper end vertebra to me. First, define what's an end vertebra.
The most tilted vertebra at the upper end of the curve is the upper end
Okay,
vertebra.
lovely. So point out which is the upper end vertebra in this curve.
So this will be the.
This is the upper end vertebra.
Yes.
Okay. Once again, it's a loaded question. You have to ask me, sir, of which curve? Each spine can have how many end vertebrae? Yeah, it can have up to 6 end vertebrae because each spine has 3 curves. So do not look at a spine as a single curve. Though this obviously looks at a single curve, you cannot look at a spine as one curve. Even if it's straight, it's still 3 curves. Each spine has 3 curves. So when I ask you which is the upper end vertebra, you say which curve. And then, or you can say the upper end vertebra of the main thoracic is this. But you can't say that's the upper end vertebra. Because I'm going to say, I wanted the proximal thoracic, right? What's the minimum number of end vertebrae that each spine can have? Maximum is 6, 2, 2, and 2. Minimum is 4. Yeah, so 2 can coincide, right? The upper of the middle curve and the lower of the upper curve could coincide. So it will be 1, 2, 3, and 4. So 4 to 6. Great. Okay, so you say, can you again point out to that upper end vertebra, and why do you think is the upper end vertebra? Point out. Okay. So we are going to call that T4.
Yes.
Okay. Does anyone? Why do you think is the upper end vertebra?
Because the angle between the lower end plate of the upper vertebra and the upper end plate of the lower vertebra is the most.
Okay. So basically you feel it's the most tilted vertebra.
Tilted.
I'm challenging you and saying this is actually the more, you're saying this is more tilted. I'm saying this is more tilted. Okay. Does anyone who believes me, who feels, just put your hands up. The Tejas said this is the most tilted vertebra at the upper end of the curve. I'm saying this is the most tilted vertebra at the upper end of the curve. Who thinks I'm right? Put your hands up. Because I'll be asking the others who are not putting their hands up. Okay. Okay. So Abhishek, come. Please. So quick. Just you don't even have to come. You can answer from there. Why do you think this is more tilted than this? Can you prove to me that this is more tilted than this? So what I'm getting at is that the first way that you identify the end vertebra is look at the tilt. If the tilt is very clear, you don't have to get into the hair of end plates, etc. Right. So what would you do next to prove to me that what you're saying is more tilted than this one?
So maybe look at the shoulders.
Not shoulder, because shoulder is totally unrelated to the end vertebra. Yeah. Say loud. Right. So let's let's put that in place. I've drawn. So your answer is absolutely right. If there's a difference of opinion in a visual impression, because you may like blue, I may like light blue, and then there's no definition, right? There's no objectivity. To get an objectivity, I'm going to draw the end plates. Okay, and here's the upper end plate of the upper, and then the next one. Okay. Again, here there is subjectivity because my parallel to end plate could be slightly different than your parallel to end plate. So here I'm seeing that this one is actually going away. This one is actually tilting into the curve. Okay. So at least this photo makes you feel that I was right. Okay. So when you talk of end plate, so is everyone in sync with the discussion? If it's very clearly tilted here and the other one is not, that's your end vertebra, no further discussion. But if there is a controversy, there are two controversies that will happen. One is that the upper one is more tilted or not. You draw end plates. If you can't see the end plate because of rotation, what do? If the end plates are not clear, yeah, do tangential lines on the top of the pedicle, and that's equivalent of the end plate. Okay. So if you find, that's good. If you find that this end plate is actually falling into the curve and this is going away from the curve, we are talking of this curve. So falling in is falling in and this is going away. Then the upper end vertebra is, the lower one is more correct. The one that's tilting in. And is it clear? Otherwise ask now. Okay, you also look at the wedging of the disc space. You want to ask, Tejas? You're also looking at the wedging of the disc spaces, that the disc spaces should open up on the convexity of the curve, which means close on the concavity. If this is happening, this one's probably opening here and closing there. Okay, if it's opening here and closing there, this can't be the end vertebra. Okay, now the second controversy is supposing these lines had turned out parallel. Okay, right now I'm saying this line is going away, so clearly I'm saying this is the upper end vertebra. But supposing they had turned out parallel, which would be the upper end vertebra? That table, someone, Gaurav. Supposing these two lines are parallel, which means this bone and this bone are equally tilted into the curve. Anyone?
Sir, upper.
No, lower. The one that's closest to the apex becomes the end vertebra. So when Tejas gave us a definition, the qualification of the definition has to be that the most tilted vertebra at the upper end of the curve closest to the apex of the curve becomes the end vertebra. Okay, is that clear? Okay, now lower end vertebra, Tejas' neighbor. Is that Delhi? Not a Delhi. Who? Then your neighbor with the mask. Sorry, I don't know your names. We'll get to know everyone's names very soon. Come up, no? Acha, you can say this. Say this. Tell me which is the lower end vertebra according to you. You need to point out. Sorry. Right. You can point out which is the lower end vertebra. Press that ball. Yeah.
This one is the lowest.
Okay, so I'm this is the 12th. So let's name it. This is T12. So you're saying L1 is the most tilted vertebra. Anyone has any challenge to this? Does anyone feel it's T12 or L2? Who agrees that L1 is the lower end vertebra of the main thoracic curve? Who agrees? Put your hands up. So everyone feels it's not. So who feels it's not? Put your hands up. Joseph, which one is the end vertebra according to you? Lower end vertebra?
Lower vertebra is end vertebra of the
you
thoracic
feel this
curve.
Is the lower end vertebra?
Yes, sir.
And what's your name? Sorry.
Uday.
Uday says this is the lower end vertebra. So how do you sort this argument? We go back to the same rule. We draw our end plates when the computer stops hanging, and so what we are looking at is we are looking at the disc space in between. Okay, so to sort, just take that, just go to sleep. So you look at how this end plate looks or how this disc space looks. So I've drawn two, one on Uday's lower end plate, one on Tausif's lower end plate. How does this look to you now? Tausif, do you still agree that, do you still feel this is the lower end vertebra, or do you feel this is the lower end vertebra?
So I still feel that this is the L2 is the lower end vertebra.
Means you feel this line is more tilted than this line?
Pardon, sir?
This is L2. You feel the L2 looks more tilted than the L1?
Yes, sir. I still feel L2 looks
what
more.
What about you, Uday? What do you feel? You feel this is more tilted? Yes. All right. Anyone has a difference of opinion? Uday?
Sir, I feel it is L1 or D12 and not L2 for sure.
Right. So you can see so much subjectivity. Anyone has any way of overcoming this?
Because the upper here, the L1 end vertebra is either parallel or within the curve. So of the L1 and L2 in the current slide, it is L1 more than L2. Yeah.
So I'll tell you where the problem is coming. That see this space is clearly opening up on the convexity. Okay. This space is clearly opening up on the concavity. So I think this and this are very clear, which means that this can't be the end vertebra. This can't be the end vertebra. We are talking of three bones which are roughly looking parallel or stacked up. Yeah. You want to say something? No. So now I would closely analyze the disc spaces. This to me looks fairly parallel. Okay. This, I mean, the way you look at it could look parallel or it could be opening up here. This one is clearly opening up here. So, according to me, it's going to be one of these two. But there's a lot of subjectivity here, and you ultimately should be able to argue your case. You see, right? There's three different people have said three different things. No one is totally correct, but on the good side, the difference in these is very marginal. right? So if you called this one and I called this, you would not make a gross error. Okay, so as long as you're getting into the best averages, you're still okay. Don't get so stressed about me saying T12 and you saying L1. It's okay, because the error is not that big. But a clearly tilted vertebra, if you call it an end vertebra, it's a problem. And we are trying to run this drill because you get X-rays from either which have been marked by another surgeon, and they've totally got it wrong. So your angle measurement is wrong, so everything goes wrong. So you get into the habit of, you get that app, which is that app? Angle Pro. All your phones should have that Angle Pro or whichever app with a goinometer. So you should be able to, first of all, know your end vertebra. So the radiologist often labels the end vertebra, and they are again totally clueless. They are more wrong than right. So if a radiologist is labeled an end vertebra, you say this is not the end vertebra for sure. And you find your own end vertebra, find the angle, and then make your own assessment. Okay. So that's as far as end vertebrae are concerned. Yeah. Akshay, yep, that was a good comment. Comment. So we've got some satellite faculty also with us, and Akshay says that Dr. Akshay Gadia from Aurangabad, he's a well-known spine surgeon who's also done a lot of deformity work. That Kawakami's paper says that 30% of congenital scoliosis are missed on plain X-ray because you can't assess the posterior elements, and that's a paper he's quoted. Hence, no evaluation of scoliosis complete without an MRI scan or a CT scan. So when we asked the question in the beginning, is this congenital or AIS? Even if there were no features of congenital or non-AIS, you should still get an MRI and then say that this is non-AIS. So as far as practical, practice is concerned, you have to have an MRI for all cases before you call it AIS. What were the other comments? For marking the end vertebra in case of controversy, and if not able to see the end plates, you can use a line tangential to the superior border of the pedicles. Great. So we discussed that. Want to go lower? Okay, only 2 comments. I saw some more comments. Okay. Okay. Right. So next. So these are the 3 lines that we drew, and you can see, depending on how you look at it, according to me, this and this is parallel and this is opening the other way. So I'm actually going to call this T12. That's going to be my lower end vertebra in this particular case. But you can argue that I've drawn that line slightly odd and you would draw that line differently, and all that argument is legit. But if you make this your end vertebra, no one in the world will argue with you, and you're totally legit to do it. Okay, then you. So now these are done. We've also cursorily marked, do not forget, like I said, to mark the end vertebrae of the other 2 curves before you move forward. Okay, then next. Okay, now we want one volunteer, maybe. Which is the stable vertebra here, and how will you find out which is the stable vertebra? Sanjay.
So if we draw a line parallel CSVL line.
So how to draw the CSVL line?
Through the center of the spinous process of the sacrum.
But how do you know that it's vertical? So the first step, so you're right, to know what's a stable vertebra, you need a central sacral vertical line. It has to be central, which is okay, you know the center on the X-ray. It has to be sacral, you know the sacrum. But vertical, you don't know, right? So there, you first want to draw an intercrestal line. And then you draw a line that's parallel or perpendicular to this intercrestal line. Okay. Now there's a bit of a controversy here, which I'm going to slightly touch upon, but not dive into it. There's some surgeons who feel that if the crest is up and down, then the intercrestal line does not truly represent, then your CSVL goes non-vertical. Personally, I believe that I'm going to look at the pelvis in an AIS. I'm going to look at the pelvis as the base. So if there was something here, it's positioning, because an AIS should not have any infrapelvic pathology. Okay, so I would always in an AIS go by the intercrestal line. In a non-AIS situation, it helps you to go by a actual flat line. So if you're, all I'm saying is that if your intercrestal line does not look horizontal, you got to immediately think about infrapelvic pathology, because that will affect your decision making. This is not a part of today's discussion. This is non-AIS. But in AIS, the intercrestal line should be a horizontal. Okay, because then any error is a observational error or a X-ray error. It's not a problem with the kid because in AIS. Okay, so now that I've drawn a intercrestal line, that's my first step always, and then a central sacral vertical line, which is now your stable vertebra. Do you want to point out?
L2, sir.
Point out.
This one.
Why is that your
Because
stable
the lowest vertebra closer to the curve, which is touched by the CSVL.
Yeah, so you're right, but you're wrong. So the definition of stable vertebra is the vertebra that is best bisected by the central sacral vertebral line. And clearly the L2 is not best bisected, the L3 is best bisected. The L4 also is as good bisected, but it has to be closest to the curve. Okay, so that's one controversy. So stable vertebra is a definition given when we were looking at stable zone, when we were doing the primary type of, not the third generation system, but that definition still holds, right? So you can't change that definition. So that definition is related to gravity. And hence a stable vertebra in this case will remain this. It's a different thing that you may use this or this as your lowest implemented vertebra. But the stable vertebra, the definition is very watertight. It's the vertebra that's best bisected by the central sacral vertical line. Any comments? Anything, any difference of thoughts? You're just anyone who disagrees, no? Please just get into an argument. Don't just believe what I'm saying, because there'll be some things that you may know which I don't know, and it's totally okay. And if you are wrong, it's still okay. Let's convince each other, but don't just accept what I'm saying and move on. Otherwise, you'll never learn. That part is left as it is. And I can tell you for sure that every scoliosis week we conduct, I go back learning at least 5 or 6 new things. So just, if you've read something, just argue, okay? Because if you don't ask, I'm going to ask. And then that's just going to keep on happening. So your neighbor has not, what's your name? Prithvi. So Prithvi, this stable vertebra, is it a stable vertebra of this spine or is it a stable vertebra of the main thoracic curve?
So it's of the main, it's of the spine.
Yeah, in this case, it's the spine and the main thoracic curve. But yes, I'm saying this because sometimes there's a proper, thoracolumbar curve, which is quite major. And then you can have differential stable vertebra, right? Each curve will have their own stable vertebra. That's okay to think about when you're thinking of selective curve fusion. But a stable vertebra still remains a gravity definition. So it should be the lowest one. So when you're thinking of a stable vertebra per se, there's always one stable vertebra in the entire spine. What are your thoughts, Arjun, on this? Because this has always remained controversial. We've all grown up on the primary correction system. So we've gone by Harrington's definitions. And I believe that once the definition is made, you can't change that name. So the lowest one remains the stable vertebra. But sometimes when you have a significant S-shaped curve, this one will have one stable vertebra and this one will have one stable vertebra. And you have to respect that if you're only planning to correct one curve. But if you're correcting both the curves, the lowest should be your stable vertebra. Is it okay? Anything you all want to ask or don't agree? Anything? Arjun, if you want to say anything. So after this, we would all agree that this is the stable vertebra. Any volunteers for apical vertebra? Whoever has not spoken, just volunteer. Who's everyone spoken? So maybe samne aao. Gajendra, or you can sit there. You can use this. You just point out. You define what it is and point out the apical vertebra. What is the definition?
Farthest vertebra from the CSBL, vertebra or a disc that is apical.
So largely you're right, but the definition is still not that. Like definition of any vertebra is not the end plates opening. It is the most tilted vertebra.
Yes.
So definition is always descriptive.
Yes.
So the apex of the curve is the apical vertebra. Okay.
Yeah, yes.
By qualification, it becomes farthest from the central sacral vertebral line. By qualification, it's the most deformed vertebra.
Most
rotated
vertebra. Yes.
Okay. So the most rotated, most deformed, farthest, but forming the apex of the curve. Okay. So here, can you point out which is the apical vertebra?
This one, sir.
9, T9. That's
the-
T9. If you're calling this
12,
T12.
11, 10, 9.
Okay. So I'm saying it's T10. Tejasvi, can you resolve our argument? He's saying T9. So when you're seeing a case and planning, if you say, according to me, this is the end, L3 is the lower end vertebra. First, after calling it the end vertebra, step out and say, no, but it's L2 and argue with yourself why it's not L2. Then you say it's L4, argue with yourself why it's not L4, and then you will home in on especially the lower end vertebra becomes quite important.
some most deformed one. So the lower one, this it is more rotated compared to the upper one.
So T10 is more rotated according to you. So you would believe T10 is the apical vertebra.
Yeah.
Okay. Okay, that's a fair argument. So how do you resolve this? Can you press the next? So the way to resolve this is to take your CSVL and drag it laterally, tangential to the curve, and see where it's skinning the curve. And here you will see it's skinning the curve at a disc. The part that's touching is actually the disc between 10 and 9. Can you see that? It's not one bone. So in this particular curve, the apex becomes, like you rightly said, the disc rather than a apical vertebra. So which becomes the apical vertebra here? T9 and T10. Okay, so there's no single apical vertebra. This is all important because these are definitions. It's like your name. Your name cannot change whether you're on Venus or on Earth. Just like that, the apical vertebra remains the apical vertebra, whichever book you've read. And these are definitions. So here, this T9 and T10 are the apical vertebra. The apex of this curve is a disc. Why is this important? Because when you're instrumenting, you need to have implants in your apical vertebra, which means here you want to have implants in 2 vertebrae. 2 screws in T9, at least 1 screw each in T9 and T10. If it was just 1, then you could have had it in 1. Okay, that's the rule. You can tweak it, but that's the rule. You want to follow a blueprint and then make your own rules on top. In scoliosis, there are no rules, but you have to have a blueprint and then you make your own rules. You can't be random from the beginning. Is that okay? Okay, now this is a good question, and anyone who thinks who understands scoli in this particular in this curve, which bending film? Hang on, there's some comment. Counting ribs is important, right? So Akshay says counting rib is important. So now I'll just tell you that funda, that labeling is sometimes a big error, right? So to speak the same language, the convention we follow is that the last rib is the T12. Okay, it may be totally incorrect, but at least we are speaking the same language. So at least when we are discussing, we call T12 the one with the last rib. But in your head, you should have the labeling right. You can't have called it L4 and on the this thing you do the last mobile when L4 was the third last mobile. Okay, so I think what Akshay says is true. Which bending is the more important bending?
Sir, right bending will be more important.
So a corrective bending of the main thoracic, which is the right bending film, is more important. Wrong. Why wrong? Anyone? Yes.
Sir, I think both bending films are important.
No, you have only one allowed. Both are important. Like I want to marry this girl and that girl. You marry only one girl.
Then the left bending is more important to determine the LIV of the.
Absolutely. Yes. Right. So when you in here, the right bending film is attractive because it's telling you how flexible the curve is. But really, it doesn't matter because if it's flexible or not, you have to do your work. The deal about scoliosis surgery, once again, this is the bottom line take-home message, is a surgeon who can correct or balance a scoliosis using the least number of fusion levels is the winning surgeon, not the surgeon who gets a better angle correction. So I may correct an 80-degree curve to a 0-degree going down to S1, and Arjun may get it to 20-degree but balanced, but going to L1. Clearly, he's the better surgeon. Okay, so in short, we as scoliosis surgeons today are trying to balance, not correct, using the least number of lumbar levels. Right? So here, my interest is not how much I'm able to correct. That is a secondary interest. It is an interest. Primary interest is what's my lower curve correcting like. Got it? How much can I leave the lower curve? Okay, so there's another deep funda that you should understand is that scoliosis is like a bad classroom. Okay, there's a classroom and there's one really nasty boy, and then he has influenced his 2 neighbors. Then 3 of them have influenced 4 more people and 8 more people. So the nasty boy is the apical vertebra. Then the 2 more are the next and the 3 more are the next. But by the time the teacher finds out, there are already 6 or 8 nasty boys in the class. Okay, it's if I take all of them and throw them out of the class will be again all good. But I've ended up missing so many students in my class. Okay, so if I'm able to find out which are the really nasty guys who will never change, I'm going to throw them out and the others will change. Right? So that's the rigid segment versus the compensatory segment. So as a scoliosis surgeon, you're dying to find out which part will align if some part is corrected. Right? So here, this is the part which is actually not a curve. It's just bent because the spine is bent. So why should I punish this part? Why should I include that in my curve correction? So I want to correct this curve, leaving as many segments of this curve mobile as possible. For that, I need to see the concave bending of the main thoracic curve, which is the convex or the corrective bending of the lower curve. Is that clear? Okay. So what I'm trying to see is that my stable vertebra was going to be L3. Can that go higher? That is the bottom line. Is that clear? Gaurav, are you understanding? You're like very new into spine. So if you don't understand, ask. Tejas, understanding everyone?
Naming all these vertebrae. What is the importance of identifying all these vertebrae?
Yeah. So it's a good question, but the question itself is not allowed. It's like saying, why should I know that your name is Priyannk? And why should I know? Because anyway, we are working together. Anyway, you're going to be taking the lecture. So you need to have a road map created when you do. So what he's trying to ask is that actually, are you going to make a difference once you've identified your end vertebra? Like, how does it help you? It helps you roadmap your scoliosis. Okay, so it was a loaded question, obviously. So you still need to know your, your strategic vertebrae by name to be able to roadmap your scoliosis and decide based on that. You build up on top of that. So we'll do now a bending film, and now Sanjay, maybe you again can tell us. I said that the left bending film is far more important. Now, does your perspective change here about your stable vertebra? So again, you want to draw the intercrestal line?
Yes, sir.
Draw the intercrestal line. Sorry, the end vertebra. Okay, sorry. First, let's not worry about the stable vertebra. What about the end vertebrae? Can you press those lines? So we had said T12 was the most, or maybe some of us said L1 was the most tilted. But now when you reassess this, on corrective bending. So when you're looking at end vertebrae, it has to be corrective bending. Okay. You see that it's the upper one which becomes more tilted. Okay. You can sit down. Actually, I'll get you back in. So now on corrective bending, suddenly this becomes your end vertebra. When on neutral or standing, this was your end vertebra. Okay. But as we said in the beginning, the name of the end vertebra can't change. This curve has L1 as the lower end vertebra. So this now becomes an intermediate vertebra. You can't call this an end vertebra. So that's a controversy many of us don't get over, that bending mein to T12 aa raha hai. So now which is the end vertebra, L1 or T12? So L1 remains the end vertebra because end vertebra is defined on the standing AP X-ray, and T12 becomes the intermediate vertebra. Ditto on the upper film. Next dot. So on correction, it remains the same. So the upper end vertebra has not changed on the corrective bending. The lower end vertebra has gone up by one level, and that's the intermediate vertebra or the corrected end vertebra. Okay, next. Why is this important? Because this tells me which is the stiff segment. Because initially my end vertebra was this, but now I'm finding mobility between these two, which means, and this has not changed. So the stiff segment becomes the area between the two intermediate vertebrae or the two corrected end vertebrae. So when you do a convex bending film, you're trying to straighten the curve as much as you can without anesthesia. The part that's absolutely not straightening becomes a stiff segment. It tells me that I have to do maximum work there. So I will study the pedicle there. I'll study how I'm going to put screws, get wires ready if I need to, etc. So my planning will revolve around working in this region. How much I can work in this region. Okay. My next planning is going to be how can I squeeze the, so can you, yeah. So Sanjay, you come back in. Now, which is your stable vertebra? So now this is the corrective bending of the thoracolumbar curve or the lowest curve. And here I'm trying to stack up the bones in the midline by bending.
So it's L2, sir, now.
Now it's gone to L2. Okay. So now clearly this line is bisecting this bone as good or better than this bone. So now suddenly this is called a corrected or an adjusted stable vertebra. This is one of the criteria, and maybe Dr. Arjun will tell us more criteria in the next case. So these 4 or 5 things are very, very critical before you actually, go embark on planning your levels. After this, there are many more. I think yeah, that's it. That's it for this. Arjun, you can load up while I just keep discussing. So, any questions? I've raised a lot of question.
Intermediate vertebrae, as I can understand from your discussion.
Yeah, it is called a stiff segment, and it's the strategic zone, which means that in that area, the surgeon has to do the most. Those are those 4 really bad boys who can't change. So I really need to hammer them out. They get straightened, the others will straighten. So again, we found the more I can correct that, the easier the others will follow. The others are made to be consistent. That's okay. Then go to overcorrection. So if you're getting X-rays, you're actually trying to emulate what the surgery is going to explain. Okay, but actually your correction surgery is so much more. It is never emulate that. For example, if you saw that X-ray, you cannot do that. If you saw that X-ray, the child was doing corrective bending of the lower, the one is plus 8 is over. I'm saying that if the rib exists, the rib impinge, more would be. So plus the child is not the easier, the child is she follow. There's so many restrictions that happen when you're doing a weight bending film, a weight roll and anesthesia. Is fine. But that's the limitation we have. So when you think of bending film is one, okay. Bending under anesthesia is one. Push prone under anesthesia is probably the best. Fulcrum bending is another available option. The multiple options available, of which the best, what comes closest to emulating what will happen during surgery is a bending film or a push prone film under anesthesia, which means you give the child anesthesia, put the child prone, and 3 surgeons give 3-point pressure and try to correct as much as possible. That will come closest to, or even a anesthesia traction film. If it's a collapsing curve, a traction film. So there are many questions. When would you do a traction or a push prone? Would you do a bending film lying down or standing up? We can't address all those questions, but if they come to your mind, you can keep asking because we are limited time. We got to move on. So there's lots more to be discussed. So we'll just address what's on your mind and what we are able to tell you right now. Thanks, Arjun.
I'd like to thank Dr. Nene for this invitation, and also like to acknowledge the hard work that Harshal and Priyannk have done here, and like to thank the event organizers and also the sponsors. Of course, everyone here for coming in today on a Sunday. So scoliosis is actually the planning and everything related to it is all about balance. Okay, it's all about balance. Just like life is about finding that balance, scoliosis surgery is also about finding that correct balance. And when we are planning the case, it's also about balance. All right. So everything starts with the patient. It's not the X-ray. All right. You want to have the patient well corrected. It's not only about straightening out the X-ray. All right. So this is an adolescent girl, and you can see, this is the clinical exam, basic clinical exam, which everyone should do. In the clinic, you need to have a reasonably well exposed spine. You should be able to see the shoulders, the spine, the waist. One needs to do a forward bend to assess the rib bump, and it's sort of the starting point. The X-rays are a corollary, but you need to start here and basically end here, because how the patient looks after the surgery is actually what defines the success of your surgery. So basically what we'll try to do is we'll go table to table. We just want to sort of, so I'd like to start with first table here, and someone can just volunteer. So can somebody just describe the clinical picture here quickly? So we'll just go fast.
Sir, here we have taken the clinical picture shows that there is a right-sided mean thoracic curve on Adam's forward bending. Also, the right-sided curve is exaggerated, and there is diminished lumbar lordosis and kind of a decreased flatter back, which is seen in a typical AIS, and she looks like an adolescent female.
And you can see the patient is a slight, there's a slight shift.
Right side with a right shoulder also, which is a little higher than the left one.
Very good. Okay. So we'll go now to the next. We'll go to the next table.
So Prithvi here will come.
So this is basically just highlighting what you want to see. So the shoulders, okay, you're seeing the rib bump. You also should look for the lumbar rib bump, okay. And now we'll go to the X-ray. All right. So can anybody? So now you'll have to tell me what type of curve is this.
Sir, it is a double curve.
First, I want you to tell me is there idiopathic or a non-idiopathic? First.
Sir, it is idiopathic, sir.
Okay.
Sir, end vertebra here will be Sir, for the upper thoracic curve, it will be D5 and D12, sir.
That's the main thoracic.
Main
not the
thoracic
upper
curve. Sorry, main thoracic curve.
All right.
And the sir, stable vertebra down will be L4.
Okay. So how do you
And
define the stable vertebra?
sir, again, the line we draw from the pelvis and the perpendicular line towards the spine, sir.
So here there are three curves, right? So
Yes,
there is a main thoracic curve, there's a lumbar curve, and there's a proximal thoracic curve. All right. So now I've drawn that line. So you'd like to sort of tell me what do you think? Dr. Nene touched on this,
Yes,
but you know, for the whole spine versus for the curve. So here in this case, for this patient's main thoracic curve, which is the stable vertebra?
Sir, L4.
No, that's for the lumbar curve. There are three curves. Someone can help from the table. Yeah. So we
From
can
the,
have helping.
for the main thoracic, it is L1.
Okay. All right. So notice here that the D12 is actually not the last rib here. Okay. So D12, if you count here, the D12 is actually, so your counting is very critical actually. You need to count carefully. Okay. So you said, Harshal, it's L1 you said. Okay. All right. Okay. Anyone agrees, disagrees? All right. Now, what is the last touch vertebra? So do you know the concept of the last touch vertebra? The last touch vertebra and the last substantially touched vertebra. There's a difference between the two. So anyone would like to sort of talk about it?
Tausif? So, sir, last touch vertebra is L1 and last substantially touched vertebra is D12.
Last substantial. I think you're inversing it. Actually.
Here, Abhay will.
You're inversing it. Just kind of elaborate again. The last substantially touched vertebra is the vertebra which is well touched.
Well touched, which where CSBL touches the pedicle.
Yes,
Basically.
okay.
So last substantially touched vertebra would be L1,
correct,
and last touch vertebra will be D12.
Very good. Okay, very good. All right. Okay. So now we can move to the next table. So no one can sleep basically at least. So, all right. So now can you tell me which is the neutral vertebra? Neutral vertebra. That table. Yeah.
Sir, L4.
What is the neutral vertebra?
The least rotated
So
vertebra.
where you're seeing both the pedicles.
Both
properly.
pedicles are
So
visible.
where? Which is it?
L4, I can see both pedicles.
Okay.
But
all right. Suppose I said D12.
sorry, L3.
Suppose I said D12. Is that wrong?
Okay. Both pedicles are seen beautifully, and the spinous process seems to be far more in the midline than here, isn't it? Or even L5 for that matter.
D12 would be the neutral.
So it's not L1. It's not L1. You're clear, right? It's not L1. Yes, you can see that the pedicles are not the same, right? It's not L1, right? So you have to differentiate. The stable may not be the neutral or vice versa. Okay. Okay, we can move to the next table. So can you define the end vertebrae of the main thoracic curve? Main thoracic curve, what is the end vertebra?
Yes.
Proximal.
Proximally it is 11, 10, 9, D5.
Okay. And now tell me, what will the levels of fusions have? What are you going to fuse? This spine, what are you going to fuse? What would be your levels of instrumentation?
I would like to see the bending films.
No, suppose I'm asking you to tell me right now. I'll show you the bending. I don't use the bending to decide the levels actually. So, but I want you to tell me on this.
D5.
You can guess, it's okay. Upper level and lower level. That's all.
Yes. So it will be D5 to D12 or
D5
L1
to D12. Okay.
or L1.
Or
L1.
okay. All right. Okay. All right. Anyone has any other levels here? Anyone would like to sort of differ or give a contrary view?
Who agrees?
Who agrees and who disagrees?
Who says T5 12 T12 is good? Put your hands up. If you don't put up, then you are disagreeing, and I'll ask you to tell me what you mean by disagree.
So D5 to D12, raise your hands. D5 to D12, raise your hands. Raise your hands. Whoever wants D5 to D12.
Everyone wants a question why it's not D5 to D.
You say it's not T5 to T12. What are your levels?
Sir, according to King's classification, it comes under type 3. We can go for selective thoracic fusion, but it is better we go from neutral vertebra to neutral vertebra in this. That will be around D4 to L1 maybe.
What is the Lenke classification?
So all the three things you said are disconnected.
Yes.
Selective thoracic belong to King 1 or King 2, not to King 3 by definition, because
Yes.
King 3 is a C-shaped curve. It is like Lenke 2.
Yeah.
Okay. So that was one connect. The second thing you said was neutral to neutral is only Suk's theory.
Yeah.
Sel Suk from Korea, his theory is that every case you go neutral to neutral. It's got nothing to do with King's classification. The third thing you said was, so all the three things are disconnected. So let's not argue right now. Just give your levels, and then we'll ask you the reason. What are your levels? If you're the surgeon, what levels would you fuse?
Sir, D4 to L1.
T4 to L1, so
Yes.
1 level higher and below.
Yes.
Okay, that's good.
Now come back here. What is the Lenke classification?
Sir, here we still need to know the angles. But
both
it's
are,
a double major.
Both are above. No?
So it's a double major curve
Yeah.
here. So it's a Lenke type 3.
Lenke type 3.
Or
Why Lenke type 3?
Lenke
Why
type
Lenke type 3
6?
and why not Lenke type 6?
Sir, because clinically patient had a bigger rib hump as compared to the loin crease. So that's why clinically it looks like a Lenke type 3 as compared to Lenke type 6. So here we'll also need to get bending x-rays to know the flexibility to decide whether we need to do a selective thoracic fusion or go entirely till L4.
Very okay. Now, so I'm just going to summarize the Lenke classification. You have to talk in the Lenke classification in today's time, like for you all to understand. So basically, the Lenke 1 is a main thoracic. A Lenke 2 is a main thoracic plus a proximal thoracic structural. A Lenke 3 is a thoracic main with a lumbar, with the thoracic being bigger than the lumbar. Now these first three were the main thoracic types, the main thoracic. The 4 is everything. Proximal thoracic, middle thoracic and lumbar. The 5 is a main lumbar. Okay, so mainly a lumbar curve, and the 6 is just like the 3, but the lumbar is more than the thoracic. So basically 5 and 6 are the lumbar curves. 1, 2, 3 are the 1 and 2 are the thoracic, and 3 and 6 are equal. It's just that they interchange. Simple. All right. Okay. Now,
question.
Is proximal thoracic curve defined or not defined yet?
It is defined.
Sir, then how will we define the proximal thoracic curve?
So now here, if you look at if that proximal thoracic curve is about 25, and how will you understand that clinically? So if you go back to the clinical picture, go back to the clinical picture. The right shoulder is higher here, which is the main thoracic curve.
The right.
Right. If the main thoracic is on the right, and if the left shoulder was higher, then what happens?
Sir, I mean,
then it becomes a 2 because
the opposite side.
Because then you know that proximal thoracic curve is structured, right? It's just
I meant to ask that like the apex and the angle measurement for main thoracic curve is fixed that the apex should be around between D5 to T11.
Yeah.
And so is it that for the proximal thoracic curve it should be
D2 to
between
D5.
T2 to T4?
Yeah. Okay.
Why he's asking that? It's a loaded question again, because there's some fractional curves on the top. Sometimes the proximal curve doesn't find the end because it goes into the neck. Either you don't see it or you don't see the end. So sometimes the apex can be floating. So if you just go purely by definition, sometimes you may not have an apex in the regions that have been defined by Lenke. So all you need to know is the concept that there is a proximal curve. And is this proximal curve worth looking at? Which means is it causing an imbalance in the shoulder? Or is it not worth looking at? I think that's grossly good enough for you to know.
Okay. So now we come to the lateral X-ray. Anything on the lateral X-ray here? Table 2. Anyone on anything that you want to comment on the lateral X-ray?
Last table is correct.
Come on, the Joseph's table. Whoever wants to comment. Is it
So what you'll see on the lateral X-ray?
Sagittal profile here?
So in lateral X-ray, we would like to see the thoracic kyphosis and
Kyphosis or lordosis? Yes, this is. So what are you seeing? Is this kyphosis or is it? So there are 3 types. You can have normal, hypokyphotic, hyperkyphotic. What is it?
So it is hypokyphotic.
Okay. Anything lower down? Very good. Very good. So there is a listhesis at L5S1. Good pickup. Very good. All right. Good.
So is there a difference between all-aesthetic scoliosis and scoliosis associated with a spondylolisthesis?
Yeah. So this is like an idiopathic scoliosis, but there is an associated listhesis. All right. But so the reason I put this up is you have to have a lateral X-ray which encompasses the entire spine. For older patient, you may kind of miss everything on the lateral X-ray otherwise. So now we'll go through the planning quickly. Okay. So that's the CSVL I've drawn. So some people are choosing D5 here. How many people choosing D5 here?
Upper instrument vertebra D5. Put your hands up.
Just put your hands up now, quickly. Put your hands up. No one? Okay.
We had one, no?
Yeah.
Gajendra said T5. Are you putting your hand down or up? Down. Okay. Who says T4? Put your hands up. T4.
D4. Okay. How many people want to go to D3 here? D3.
I'm looking for people who have not put their hands up at all.
D3. Anyone? No one wants D3.
Which is your level? You didn't put your hand up for any. 5. So you should put your hand up for 5.
Anyone wants D3 or no? You don't want D3. Okay. How about D2? Anyone wants D2? No one? Okay. What about D4? D4? Okay.
Majority is D4.
Okay. All right. Now we'll go down. So how many want to end at D12? Okay. 1%. 1%. Why D12?
Other curve.
Okay. All right. Fine. Okay. Is it touched?
No.
It is touched. It is just touched.
Yes, it is
just touched.
just
right?
touched.
Yeah. Okay. All right. And how many want to go to L1? L1.
L1 hands up.
So now that means the remaining people are going to tell me another level now. Okay. So how many people want to go to L4? Anyone wants to go to L4? No one? So then where are the other people going then? Which is their level? Is there any other, I mean, is there any other level you're thinking of?
Sir, L5, sir. L5.
L5?
Yes.
L5 all the way. Okay.
So why L5? What's your thought process?
Postoperatively, compensatory curve developed in the lumbar region.
Okay. So if
So you want to be safe and just take both the curves and not let the other curve spin out.
So I say, so this comes down to what instrumentation you're using. So if you're going with the heart shield, you're kind of going to go down all the way. All right. If you're going with the modern instrumentation, then you will go proximally. And actually, if you ask me what is the main advantage of using the modern system, it's that you can save more levels. Okay. That's really the main advantage. It's not so much about anything else. You can get a very good correction, but you can save levels in the lumbar spine with most of the modern instrumentation systems. Okay. So this is that which you got to pick up. Now, if you wanted to go to L5, what will happen here? You're going to end at the, you only told the answer that there's a listhesis, and now you gave us the answer actually. So, okay, so you can't end at L5. That's a wrong answer here. Okay. All right. So these are the bending films. Now, anyone wants to revise what we are talking about? Okay. So I'm just quickly marking out, what you need to know from here. Okay. I marked out what you need to know. So so it's confirmed as a Lenke 3. Why? Because that lumbar curve is correcting down, right? Okay. And you can see that thoracic curve is correcting to some extent. All right. Okay. Anyone would like to revise now based on the level, level planning on the bending films? Anyone wants to revise? or everyone will stick. So basically, this is to show you that you don't need the bending film to plan. You can decide everything right on that AP. Okay, if you have a good AP and you have a good lateral, you can actually decide everything on that. All right. The bending is only to corroborate. The reason I don't ever use the bending is because there is variability in the way the bending film is done, and you don't know how the bending film is done, how much the child has bent, who has supervised that X-ray. So unless you had a very well done fulcrum bending, etc., it's very difficult for us to use that as your primary interpretation. Everything should ideally be done on the standing because that's standardized. Okay. So we'll come to so this is the fulcrum bending. So how you do it. This is actually the way you do the fulcrum bender if you're going to do it. Okay. This is more objective. You put a roller and put the patient on the side. All right. And then you calculate. Okay. You always see the MRI. No spine patient should have surgery for scoliosis without an MRI, because the ones who look idiopathic may also have a MRI anomaly, and if you miss it, there'll be a problem. Okay, so always have an MRI before to check that there's no teeth. This is intraoperative radiograph. So after I've completed, I've checked to see that my CSVL is matching up here. Okay, because if it's not matching up with the patient prone under anesthesia, there's no way that the patient is going to wake up with a compensated spine if you're planning to go selective. All right. And this is what I did. So you can see here, what are the levels final? We ended at?
Looks L2, sir.
That's L1. I'd mark 12. Remember, the last rib is on 11 here. So it's 12, 1. And proximal level is? What's our proximal level? Anyone? 3 or 4? It is D3 here. Okay. So you can go to D4, you can go to D3. It depends on you and how much you want to balance, because your shoulders, see, you have to balance the shoulders at the end of the surgery. Okay. And this is the patient after a year. Okay. So you can see that the lumbar curve we have left. Okay. And this is actually at 2 years. Okay. At 2 years, the patient is doing reasonably well. All right. And this is the way the patient looks. Okay. Eventually, everything comes down to this. How is the patient looking at the end of the surgery? All right. I mean, it's not about you straightening the spine. It's how the patient looks clinically. All right. And you can see that the patient is fine, has a good thoracic kyphosis, has a good lumbar lordosis. The waist is symmetric. The shoulders are level. All right. That's really what you want to achieve. Thank you.
Awesome. Awesome. Thanks, Arjun. And we'll go through some more levels. I encourage, we have some coffee and stuff outside. It's been a toxic session. So go and pick up your coffee and come back in. So we don't, so take a short break. Like
Yes.
5-minute break, get your coffee and come back in. So we'll discuss selective thoracic and some more level planning before we get on the hands and inflows. Is that okay? Utho?
Yes, sir. Yeah,
Normally you're dying
coffee,
to
coffee.
Get coffee and snacks and come in.
Yeah. So quickly get coffees and come back.
ये बंद किया है, बंद कर दिया है ये. It's not starting yet. हाँ. अच्छा.
सर कर रहे हाँ ये वाला
अरे वो उधर फ्लिप हुआ. अरे वो उधर फ्लिप हुआ.
यहाँ पे सेम वो उल्टा हो गया ना. वो ऑलरेडी मिरर व्यू था. वापस वैसा हो गया.
The strategic vertebrae, just to remind and go through what we discussed so far. We discussed first the corrective maneuvers. Before that, we discussed the releases that are done. We discussed the strategic vertebrae and some things about level planning. We will now talk about some special type of level planning when you're not taking the whole curve in. And we'll leave level planning there and then move to hands-on where we'll talk of the techniques and we will get to see the techniques. So what we are not going to do is any more discussion about levels and different types of cases. And is that okay? Because time-wise, we are a bit restricted. So we'd rather spend a couple of hours on the bone model than just theory. So we had an option, but we are choosing the other one. So Dr. Priyannk Patel will take us through a case which involves selective curve fusion, which has slightly different rules. All yours.
Yeah. So basically, this is a 15-year-old post-menarchal girl with a progressive deformity which she noticed at 11 years of age. She's done all the conservative treatment, and that's her clinical profile and the X-rays. So this is how the X-ray is. Now, any thoughts on how anyone would manage this curve? We've gone through the entire basics. So anyone to volunteer? Did I? How are you thinking?
So first of all, she's a post-menarchal 15-year-old female, and without any deformities that can be seen on X-ray, which is classical with a right-sided major thoracic curve. So it first comes into the mind that it is an AIS and not any other thing that we are dealing with. So after knowing that it's an AIS, then the next step is to classify what kind of lanky curve it fits into. So again, here the thoracic curve is a major one, is a lumbar curve, which is also a major, but the angle is smaller. So this fits into a lanky type 3. On bending X-rays, it looks like the lumbar curve is flexible, and the thoracic curve is less flexible as compared to the lumbar curve. So there are options that either we can do a selective thoracic fusion versus doing a entire thing fusing both the curves. Also, there is some shift that is there in the thoracic curve as compared to the lumbar curve that signifies that it's a major curve as compared to the lumbar. So our primary goal will be correcting the thoracic curve and either aiming to prevent any decompensation in the future or fix it primarily so that we don't need to bother in the future.
So just to get everyone on the same page and to start thinking like a scoliosis surgeon, number one, is the patient require surgery or not? That's the first question. Once we go beyond that, then we need to classify and identify which type of curve it is. So here you have a thoracic curve and a lumbar curve, and the thoracic is bigger than the lumbar curve, so it comes under Lenke type 2, type 3. Does everybody agree? Is there anybody who feels that the lumbar curve is not structural? So how do you differentiate between a structural versus a non-structural curve? Anyone? Yes. Yeah, just take the mic. Yeah.
Bending films, structural.
So you would check the bending film. So what are the criterias which have been defined by Lenke? When you bend a curve, do you know the criterias for a structural versus non-structural?
A structural curve should not be corrected on convex bending.
So is there any degrees which are there? Yeah. Sorry?
Yes.
When we
The-
active with the mic.
The curve which gets corrected
Yeah, with
on
the
bending x-rays by more than 25 degrees is a non-structural curve.
So basically, when you see in a standing AP X-ray, if you have a curve with a X number of degree, and when you do a convex side bending of that curve, if that curve is correcting to less than 25, then it becomes a non-structural curve. Correct? That's the definition by Lenke. So just look at the lumbar curve over here. Do you all feel it's truly a structural curve, or do you feel it's a non-structural curve? If you measure the angles are 66 degrees for a thoracic curve and the lumbar curve is 44 degrees. So I would probably say that the lumbar curve is a little borderline, because if I calculate the angles which I'm showing you later on, it probably is getting less than 25. Is there any other criteria where you could probably tell us if it is a structural or non-structural curve? Any other thing that we have to look at? Tosif? Apart from the bending, is there any other thing that you can look at to tell if it's a structural curve or a non-structural curve? Yes.
Sir, the ratio of corpse angle is less than 1.2. Then we can say that is not a ratio of corpse angle of the major curve of thoracic and lumbar curve. Ratio is less than 1.2. Then
No, so those are, you're talking about criteria where you want to fit in for a selective thoracic or not. So just getting back to the basics again. A structural curve is a curve which has already developed structural changes. So there is rotation which is there. It's a rigid curve which is not correcting. A compensatory curve is a curve which has been developed by the body to balance out the lower curve. So let's say you have a big thoracic curve. Okay, a patient cannot be in this position. So just to keep the patient balanced, the lumbar spine bends in the opposite direction, and that's called as a compensatory lumbar curve. Versus you have a structural lumbar curve where the lumbar curve is actually structural. There is a problem over there and it is not going to correct itself. There is a rotational component also. So apart from the bending X-ray, there is one more thing. Yeah, we have Dr. Arjun saying something.
Not be a Lenke one. Can this be a Lenke 1 curve?
So what's a Lenke 1 curve? Lenke 1 curve is where you have a main thoracic curve and lumbar you don't have a curve. Can this be a Lenke 1 curve?
You see the difference between this case and the last case. You see the lumbar is not that rotated compared to that last case which I showed. So is it possible for this to be called a Lenke 1 curve? And you look at the bends, if you can go back to the bends. So you see that bending, I mean, suppose I say it's coming down to 23.
Now what? So this is something that you need to identify when you're, that's exactly why the classification is needed. So when we started off, it could have very well been a type 1 curve or a type 3 curve. Now that depends upon is the lumbar spine structural or non-structural. Now if you look at the bending X-rays over here, it is bend like you could
So
see
just
that it's
for the
yes.
benefit of the audience, when we define Lenke classification, do we go by the numbers or we add our own criteria, whether rotation and all these things? Because
No.
Lenke defines structural curve as for 25 degree and kyphosis 20 degree. That so do we, if it comes to 23 degree, will we call it as type 1 curve?
Yes. What's the opinion of the house?
So I want to pitch in here and say that you should not follow Lenki criteria. You should not follow King's criteria. You should just it should be a benchmark to think, because he says 25. What if it's 24? Does it gross, or if it's 26? Does it make it so black and white? So the three things that Lenki should teach you is that each spine has 3 curves. The second is that you need flexibility films to see how things are stacking up. But like Dr. Arjun showed, you don't even need that. And the third is that you need to see a lateral X-ray for every case. There are only 3 things you want to take home and then make your own judgments. Okay. For example, here, if the lower curve is bending, say by 50%, but it's just short of that 25 mark, it's bending to 27 degrees. You got to still look at the rotation on AP. You got to still look at whether your bending is actually causing a costopelvic impingement. If there's a costopelvic impingement on the bending, your bending is not correct. You got to still look at the clinical picture and see if there's a loin crease. For example, your radiological criteria may suggest that the lumbar curve is non-structural, because very flexible on traction film or fulcrum bending, it's coming out easy. But on clinical AP, looking at the girl, there's a big fat loin crease there. Or there's a big fat truncal shift. That totally throws the entire gamut out. So you got to look at all criteria together and not follow Lenki by the footprint. Otherwise, you'll get it wrong. And Lenki himself says that his classification, there are more outliers than inliers. So he's just giving you a general profile of how to think, but it does not mean that every case falls in line with that criteria. So just take that home with you. And luckily, for those who are taking exams, so most of your examiners belong to my thought process. Very few of them will hardcore say कि नहीं तू Lenki का बताइए कैसे ये इतना degree क्यों? No, no one will argue over that, as long as you're giving the philosophy of Lenki correctly. Okay?
Yes.
So till now we know that this patient has got 2 curves. The thoracic curve is bigger than the lumbar curve. The lumbar curve could be structural, could be non-structural. The house is divided. The X-rays are showing something. Clinical picture is showing something. So till now we have come to this conclusion. Okay, now what? And the other thing is, why are we talking and trying to find out so much about the lumbar curve? This is where you start discussing about selective thoracic fusion and all. The entire concept of selective thoracic fusion is that you correct the structural curve and the non-structural curve will eventually correct itself. So it essentially boils down to saving levels in scoliosis, which is what the entire world is talking about. So now we move to the clinical picture. So one thing that is going to help you identifying if it is a structural or a non-structural curve is one, seeing the patient completely from the back standing and then forward bending. So if you see over here, there is a clear thoracic rib hump which is seen, but the lumbar loin is not very prominent. So here you have 2 big questions that you want to answer when you start planning for this case. One is that what approach you are going to take. Are you going to do all posterior correction over here, or are you going to do an anterior and posterior correction? Because if you see, the thoracic curve is pretty big and is rigid as well. So that is the one question that you want to answer. And the other question that you want to answer over here is, do you fuse both the curves, or do you fuse only the thoracic curve? Now let's see how we all think here. So when we talk about anterior and posterior, we've already covered this up. What are the advantages of anterior surgery and what are the disadvantages of anterior surgery? And by now we know that the advantages of all posterior surgery outweighs the advantages of anterior surgery in a AIS. So we'll come to a consensus that we are going to do all posterior surgery over here. The next question is, when we go posterior, what levels to fuse? Now, since we have decided to go only posterior, do we do a selective thoracic fusion over here or not? Now, what essentially is selective thoracic fusion? You see this patient over here, the patient has got a big thoracic curve and a big lumbar curve. And what we have done is we have just fused the thoracic curve. And you see what is happening to the lumbar curve? It is correcting itself, eventually giving out a balance. So now the advantages of this, okay, is that you're going to fix only a single segment, which is a short segmental fuse. You have left the entire lumbar spine, which is flexible and is not compromised. So eventually you get a well-balanced S-shaped curve. So these are big advantages when you're thinking in terms of scoliosis, because if a lumbar spine is completely flexible, then all the issues with, see, because thoracic spine anyways is a immobile spine. So when you have a lumbar spine which you have kept unfused, then the flexibility, long-term degenerative problems go down. But again, there are disadvantages of selective thoracic fusion. Now, there's always a chance of decompensation if the lumbar curve increases, or if it does not adapt to it, or if you end up choosing a wrong level and you end up going into the inferior curve, then you're going to have a problem of decompensation. Sometimes you might end up over correcting the thoracic curve. So these are different problems that you have to think about when you are doing a selective thoracic fusion. Hence, selecting a patient of selective thoracic fusion is very, very important. Now, what happens in selective thoracic fusion? So you see here, you have got a big thoracic curve and you have got a small lumbar curve. Okay. The criteria is that these are the broad criteria, that the thoracic curve has to be larger than the lumbar curve. Then the thoracic apical vertebrae has to be more translated than the lumbar apical vertebrae. And the third part is that the thoracic curve rotation should be more than the lumbar curve rotation. Okay, so these are brief philosophical criteria when you are thinking in terms of selective thoracic fusion. So here what you do is you just correct your thoracic curve. Okay, and when you correct your thoracic curve, this is what your patient is going to look on table. But eventually what is going to happen is that the lumbar curve slowly corrects itself and balances it out. Hence, it is very important that the lumbar curve follows all these three criteria: that it has to be smaller than the thoracic curve, 2, that it has to be less translated than the thoracic curve, and 3 is that the rotation should be less, which kind of fits into the picture that the lumbar curve is not very structural. Because imagine if you have corrected a thoracic curve and the lumbar curve is structural, then it does not have the potential of auto correcting itself. So eventually you're going to have a completely unbalanced patient. So you might have saved the levels, but the problem is that you have a bad clinical result. So now back to our patient. The thoracic curve angle is 66 and the lumbar curve angle is 41. So it has all these criteria. The thoracic curve is bigger than the lumbar curve. Okay. Then if you also notice that the apex of the thoracic curve is more translated than the apex of the lumbar curve. Do you all agree with this? Anyone disagrees? Okay. And third part, if you notice the rotation at the apex, the rotation at the apex of the thoracic curve is more than the lumbar curve. So all three criteria kind of fit into the picture over here. And here I'm thinking that, okay, let's push for a selective thoracic fusion. Now, one thing that is probably going against it is that the lumbar curve here may be structural, and then you don't want to get stuck up with that. So here I kind of ended up doing a bending X-ray, and in the bending X-ray, one thing that, can anyone point out what is it here in the bending X-ray which I'm looking for, or which you would probably want to look for? So Hriday, you want to say something? Anyone else? Can you see something over here? 1 minute, I'll just get the pointer there.
Yeah, pointer. Sorry.
What is this? You see the apical vertebrae of the lumbar curve when you are bending the patient. Okay, so a convex bending film of the lumbar curve is showing that the apical vertebrae is still significantly rotated. Okay, so this one thing tells me that, okay, probably the lumbar curve is structural. It's not a compensatory curve as what we were thinking about. So this one point is very important. Whenever you are a bending film of a compensatory curve, if after bending still shows significant rotation, then you should revisit all your thinking, because you probably have missed out a subtle structural curve. So now a clinical picture is showing that this is overtly a thoracic curve with non-structural lumbar component. But radiologically, I am not in favor of a selective thoracic fusion. So here, just a show of hand, how many would go with selective thoracic over here, and how many with only the full fusion? Yes, Arjun said anything?
So I think it's important here to understand the age and the reserve. Okay, so if the child is post-menarchal, I would go for a selective here. But if this child was pre-menarchal, then I would hesitate, because then I am still worried about the lumbar curve progression.
So everything boils down to this question. Whenever you are thinking in terms of selective thoracic versus total fusion, you want to know the age of the patient. Why you want to know the age of the patient is because if the patient is having many years to grow, then the chances of decompensation increases. Okay. The second part is, if you select a patient with a significantly structural lumbar curve to undergo selective thoracic fusion, you're going to have a problem, because the lumbar curve will not auto-correct itself. So in these patients where it is still borderline, because clinical picture is telling you that, okay, this patient is post-menarchal, this patient is not having a lot of growth remaining, this patient clinically looks like a overtly thoracic problem with not a lot of lumbar problem, but and on bending x-rays it's correcting to 25 degrees, which is borderline. The x-rays although are telling you that there is a significant rotation in the lumbar curve. So these are cases where you need experience on your side. So if you are new scoliosis surgeon, you could probably just err and fuse both the curve and you'll never have a problem. But if you're an experienced scoliosis surgeon, then you could take up this case for a selective thoracic fusion. One thing that you finally do is what we ended up doing over here. We counsel the patient for selective thoracic fusion. Okay. And then we decided that the final decision we are going to take after we place the patient under anesthesia. So the final decision you can always take after placing, because what happens in anesthesia, all your muscles relax, and when you have positioned the patient, after that, if you find something like this, you see there's a significant loin crease over here. After anesthesia, if you see something like this, this is like against selective thoracic fusion, because now you know that the lumbar curve for sure is a structural curve, and this is what we ended up doing. We did the full job. We fused the thoracic and the lumbar curve, and this is what we have gotten. Now, the important steps just before we go to our hands-on is just brushing up everything that we taught. Is first step is a very good clean dissection where you completely erase off the muscles from your from the bones, and you kind of get a good subperiosteal dissection. This helps in fusion. Second, it gives you a very good release. Next part is put in screws. You maximum number of anchors that you can put in, you should start put in. And eventually, as you mature up as a scoliosis surgeon, you can start reducing your implant density. Once you have had this, you, depending upon how bad the curves are, you can work with different kinds of releases. You can go with Pontes. You can do multiple different types of osteotomies. Here, if you see, what we are using is an ultrasonic bone scalpel doing concave rib osteotomies, which Dr. Nene had spoken about. The advantage of this ultrasonic bone scalpel is it really reduces your blood loss, and it also, I think this is the Pontes that we are showing. Yeah. So it also reduces the blood loss, and it minimizes soft tissue injury, because theoretically these ultrasonic bone scalpel don't injure the soft tissue unless and until you really poke into it. Then after doing that, you put in you select the size of the rod, always weigh in for the fact that when you're going to correct the patient, you're you're going to have some lengthening. So your rod should be a little longer than the exact measurement. Otherwise, you'll do all the mehnat and then you'll have to change the rods. Once your rods are selected, you get your rod inside. With whatever correcting maneuvers you are comfortable with. You can do a global derotation, you can do a cantilever technique. Once your rods are in, so here what you are seeing is we are putting both the rods inside together. And once your rods are in, you use all hands on board and you do your global derotation. So you see what is happening as we are rotating. Watch the curve. It is slowly correcting itself.
But if you see the concave side guy is pushing down on the other, so making sure that the rib hump is not escaping.
So you can go through this maneuver to and fro, because every time you do that, it is going to loosen up the spine a little bit. The surgeon and the co-surgeon both are actively involved. One person is pressing down the convex sided rib hump and the other person is, turning, using those vice grips and derotating the rod. Can you appreciate how the rod is correcting itself, the curve it's correcting itself as you are derotating the rod? And you see the convex side guy is holding down the rib hump with the help of those derotating devices. So once you have gone through that, then you get the finesse in, go to the apical vertebrae and start derotating it so that you get a good rotational correction at that end. You see this? This is what a DVR is. Once all your rods and all are in, then you start gun towards the, then the most important part, do not forget that this patient needs to fuse. So wherever you have done your osteotomies, make sure that you put bone grafts over there. So eventually the patient fuses and that's the final result of the patient. Thank you. So any questions before we move to the demo, the hands-on?
We have about 5 or 10 minutes to discuss because we're now shifting the camera there. The way we'll play with this is that we'll show you on that camera and you see all the maneuvers and then you break down and do it by yourself. So we have about 10 minutes downtime. So you want to discuss anything that was covered, like level planning, when to do STF, when to some parts that we left behind. We didn't totally dive into level planning. So anything that is on your mind which we have not touched upon? Strategic vertebrae. Which side to put screws?
Sir, so you asked it, said that, sir, if we are planning to insert less screws, then
camera, let's move. No? Sorry, camera, let's move. Another camera. Sit.
Which screws are strategic, which are more important than the others if we are not able to put all the screws?
Yeah. So I think the most important screws are going to be the upper
point.
instrumented and lower instrumented vertebra, because there, if you can't get those screws in, you end up adding a level to your fusion, which is the biggest sin. The next most important are the apical screws, because they are the ones that are going to correct the stiff segment. So the more screws in the apex, the better your ability to correct the stiff segment. So if you just had to use minimum screws, they would be above, below, and at the apex. Now at the apex, convex or concave depends on which maneuver you're using. So if I'm using a translation maneuver or a rod derotation maneuver, it's going to be the concave rod is going to be doing your bulk of the work. So concave side, you want to put in more screws. If it's going to be a cantilever maneuver, more on the convex side. And then I was just going to show you reduction screws can come in again on the working side. So if your working side is going to be the concave side, I'll put normal screws at the ends and reduction screws at the apical concavity, because it's going to translate it back. I'll show that to you now. While if it's going to be a convex cantilever, I'll choose one, but mostly the lower end I'll put open screws, means long taps, reduction screws. So I'll thread the rod and then to push the rod in, I have reduction screws at the bottom. Okay. Anything else? You ready? Any other questions? Yeah. Don't think, just ask. Huh? There's nothing like a stupid question.
Sir, the type of screws that you use, mono or polyaxial screws. So in every construct, do you look at what you're going to do and plan accordingly, or you're very rigid, like everything will be mono or everything will be
No,
poly?
mostly it's surgeon preference because it's a pre-decided surgeon preference. Like we can't make those decisions on table, but typically we are all, most of us here are poly surgeons. We all use polyaxial screws, and we have found our ways to overcome the flexibility that comes in the way.
Yes.
Like doing block DVRs, for example. When you do a block DVR, you overcome the fact that the screw head is, when you're doing cantilever, again, you're overcoming that fact.
Yes.
So, and good releases. Okay. But if you're getting, to answer your question specifically, if you're getting a great alignment of your screws, so you're finding all screws are uniformly coming in an absolutely harmonic, symphonic kind of manner, then you can still use a mono. Like if you feel all my screws are coming in the same line, where one screw is not like that and one like that, I can still use mono and get the best of it. But by using mono and by using COCR, you're raising the stakes. You're going, going for gold. Then if you flop, you'll flop big that times. Okay. Any other questions? So, just to get on the models,
you guys can actually. Okay.
Surgeon on the wrong side. Because it's better to be on the correct side. No? So, yeah, better. So understanding if the curve is a double major or a single major, most of us like to go by, looking at the curve and saying C curve or S curve. And that can tell us, that can tell us how you want to think. A C-shaped curve is a curve where your main thoracic is the main curve. The rest will fall in line. An S-shaped curve is where there are two hefty elements to your curve, and both need to be addressed at least by thought. In an S-shaped curve, the question asked is selective thoracic or double fusion. In a C-shaped curve, the question asked is squeezing your LIV. That's that. If you learn to think like that, then you can eventually draw up your thought process and then you reach at the same level. Okay. So, Arjun, you want to say anything? Add anything to the discussion so far? So here we have a curve. I hope you can see it. And, this, we are going to call it like a double major. And we will just show you, initially, I want to show you how to pass screws. So, we've just kept a few screws to be passed. So we are just going to discuss about the apical screws on the convex side and the concave side. I'm guessing you can see it. वरून पाहिजे असं नाही ह्याच्या हेड वरून नाही तर इकडे या मागे नाही तर आपण हे बदलू because there are more people now. If you'll just crowd here, you won't get to see it properly. So we're just trying to get it from the camera angle. Turn this. Can. Yeah. Yeah. He फिरवून टाका ना टेबलच फिरवा. Someone can. तुम्ही माझ्या शोल्डर वरून शूट एकदम घुसा.
So we'll have surgeon's perspective how to pass screws.
So this is a classic. Is good. It's still not showing end on. Okay, so the key screws to be passed are the screws at the apex, and I just want to show you that. So the first step is to get an absolutely cadaveric dissection. So you want to get all the soft tissue around here out. There are big blobs that are left here. There are blobs that are left here on the side. You want to take a cautery and just buzz it all off, and your end stage, it should look like this model. It should look as dry as this model. Here you have a lot of tissue often left. So once you get the lamina, the spinous process, clear this, you take the cautery and buzz it on the TPs and go as far laterally as you can you will realize that on the concave side, it's much easier. On the convex side, you're struggling because the rib is sitting like this. So you make a case where you put in the right angle because the cobs will not dissect it. Take a right angle, flip it over, but make sure that you actually go even on top of the rib. So the dissection should be carried on top of the TP onto the rib, and you should be able to dissociate the costovertebral junction. Cut that. Then you've got the thing on hand. After that, you buzz the cautery to see the north-south of the TP. So the TP, not only the tip, but the entire extent has to be denuded using a cautery. I'm saying cautery. Some people like to use peelers, but I think cautery is a safer bet. Now remember that between the two TPs, there's a hole that you don't want to enter because that's where the pleura lies, and that's more relevant on the concavity. So this part has to be very carefully done. Here you don't just go in like you do in the lumbar spine, buzzing around. So the way to do it is that you go to the base of the TP and then walk on top. So the next thing you want to identify, once you've identified the spinous process using your cautery, identified the lamina and identified the TP. Now you want to connect this TP to the upper lamina. So that's where you take your cautery and go up here and go down here. So you go south from the top and north from the bottom, and you'll reach to the place which actually belongs to your entry point of the pedicle screw. So everywhere you will find that the bump of the transverse process will dip in, and that dip is the slot where the TP, where the pedicle screw is inserted. Here, it's little, but it normally looks like that. So you don't see the facet, you just see that this is dipping in, and that is a great entry point. Okay, now this becomes the entry point of an anatomic pedicle. So the pedicle of the true pedicle will go like this. There's a problem with this, that the pedicle of the thoracic spine, if you see, is not parallel to the end plate. It is far more caudally pointed than the end plate compared to a lumbar spine where the pedicle is absolutely parallel to the end plate. If you see the lateral view of a thoracic spine, the pedicle points downwards. So if I go by this method, on one end, I'm getting safety because I've got my absolutely correct dead on pedicle, but my screw will end up far more caudally directed than the other screws which go more vertical. So to marry that with a rod, the same problem of the mono becomes a problem. So many of us, after identifying this, then choose the entry point slightly south, and that's called a surgical pedicle entry point, where you are entering the pedicle from slightly south, so the trajectory becomes slightly straighter rather than grossly curved. But whenever you're stuck, this is the place you want to go to. Okay, when you're stuck, especially in the top screws which are hard to pass, this is a great place to pass screws. There's a third way, which is a salvage way. So you use the bone mass at the rib vertebral junction. So there's a big fat bone mass sitting here belonging to the rib, the transverse process, and the vertebral body. So you use that entire bone mass and pass your screw. So your canal is here, you're worried about the canal, you don't know all this is flirting with danger. The way to do it is to bite the tip of the TP and literally do an intramedullary nailing of the TP. When you do that, the TP is slightly more vertical than this normally. So when you do an IM nailing of the TP, you go in, then you go out here between the rib and the bone, and then you enter the bone from the side, from the lateral cortex. So you've stayed way away, and I'll demonstrate one way of doing that. So you stay way away from the neural structures. You've got a screw that's gone through multiple cortices, a much longer screw, but a screw that's sitting well off from here, and that's an offset screw, and you may need some connector. Otherwise, this screw won't marry that screw with the rod. So that's a big problem. So some surgeons only use that. I've seen one surgeon taking a drill and just doing all screws as in, out, in, because a low IQ, low brain, high safety procedure. And then all screws are lateral. But most of us don't do that. We use that only as a salvage screw. Okay, so now once you expose this, you have to decide what probe user you are. Some of us are straight probe users. The advantage is it's dead on. Where it is, it is. It's not showing this and pointing there. Many of us use a curved probe. The probe should have a sharp tip, but not sharp enough to cut your skin. It should not be blunt. It should have nice sharp edges. In the cut section, it should look like a box. So it's cutting through on the sides, but the tip is slightly more friendly. The advantage of a curve is that through a single opening, you have multiple channels to go through. So imagine I've walked here, but I have that option also, that option. I don't have to reverse the car to go there or reverse the car to go here. This, I have to reverse the car. So if I try to medialize, I'm plowing in and creating a big hole. So here I have the option. So most of us like to use this. So once I have the entry point, so let's start maybe with the convex apex. Okay, once I have the entry point created, so the entry point could have been here, but we have chosen to go south because we are getting a surgical entry point. On paper, this becomes a junction of the bottom 2/3 and the upper 1/3 of the TP, cutting the lateral edge of the articular process. Because you've exposed all this, you've got it there. Okay. Now I need, once I've got my, so the way the footprint is made just randomly. Once the footprint is made, it doesn't matter which direction. Then when I'm thrusting my owl in, no, there are two things I want to now judge: my caudocephalic angle and my mediolateral angle. Now, caudocephalic angle is slightly easier. You go by the flat of the lamina. So if the lamina looks like this, you want to be perpendicular to the lamina. If the lamina looks like, so basically you be perpendicular to the lamina. It's not so hard. The more north your entry point, the more south you have to point. So if you are going by a classic anatomic entry point, you go by the 90° to the lamina, but go slightly more south. If you go by the surgical, you go by the 90° and 90°. Okay. So that here even the TP helps you because you get to see the entire plane. As far as mediolateral is concerned, the only indicator in this in scoliosis, see, normally the indicator is that you medialize compared to the vertical. Here, because everything is spun around, so if the spinous process was like this, I would medialize it at a sensible angle, 15, 20, whatever. Like not like this, but not like this. So you can't measure the angle, but you have to be in that 15, 20 zone. But if the spinous process is like this, I want to go there. So my spinous process tells me how much I have to medialize. Okay, it becomes tricky and hard. So doing the convex side is easier for two reasons. One is the pedicle is far more better formed on the convex side, and the neural structures are pushed on the convex side. So even if I poke something here, there'll be epidural fat here, but the spine will be draped on that side. So always start with the convex side, so you can make the error. So what I'm doing is doing a gear shift, which means I'm starting pointing out, not starting pointing in. Okay. So after I made my first starting footstep, I'm using this pointing out. I'm trying to be perpendicular to the lamina and trying to, in relation to the plane of the spinous process, which is now here like this, I'm trying to converge. So in relation to gravity, I'm actually going parallel. So if it was a normal spine, I should have been going here. But because the spinous process is here, in relation to the spinous process, I'm converging, which is actually probably diverging. And I'm taking this outwards. I'm happy to make an outward error, but not happy to make an inward error. Okay. Now the way I'm doing it is the end of my probe is touching multiple areas on my skin. And if you do this, you're not getting a haptic feedback or a touch feel feedback. When I'm doing this, when I'm feeling him like this, I know which part. If I feel him like this, it could be any part. You understand the difference? So this is my eye, and the eye is, so this is your navigation actually, and then this is the computer. So when this is going through, what that is feeling, this multiple, so many sensory endings in the hand, that tells me resistance aa raha hai, aaram se ja raha hai, give way. Now remember, the pedicle wants to accept the probe. The pedicle is a path of least resistance. It's when you push, it tends to break. So you don't want to push. You want to make a movement that's limited to this. So we say 11 o'clock to 1 o'clock at best. 11 o'clock, 1 o'clock, 11 o'clock, 1 o'clock. You can't do that, and you can't hammer. Okay, and you can't hold here and hammer. So by doing this, I'm coaxing myself across. If I feel that, oh, it's not going, I have the option of coming out, turning this in, and trying the other trajectory. Okay. So eventually, because this pedicle is this side, I don't need to do a gear shift. It is coaxing me in. Okay, which is probably the pedicle. Okay, you can see it from the outside. Whoever on this side, you can see it here. Now, in scoliosis, the screw need not be bang parallel and beautiful looking. It can even go into the disc space as long as it's not hitting the neural structure. So if I get a good hold here, okay. So I'm feeling the hold. The hold is good, and the neuromonitoring guys are not saying anything. I'll accept this. If I check it on C-arm, it look weird because the whole thing is turned. You'll have to keep adjusting the C-arm about 20 times before you can get a good view. So you don't take that. Okay. So we pass that screw here, screws. So I take a probe. The way to check the probe, so there are two types of probes. One is a hard probe and a soft probe. The soft probe is a checking probe. The hard probe is a path creating probe. So many of us, after doing the first 15 or so, we now are facing a cancellous bone. We compact the cancellous bone using this. So this becomes my owl, my lanky probe. So the first 10 or 15 is made by the sharp one, and then I compact using this. But to feel, this is not a good one. To feel, you need a soft feeler. So there, now the mistake is to do that, tuck, tuck, tuck. That's not good enough. I want to lick almost the medial wall, then the inferior wall, then so walk this along. So I need two hands for that. I can't do it with one hand. So with two hands, with a 3-point feel, I'm doing that and this, and then I know I'm at the right place. And then tapping is optional, but tapping helps the screw go to the path that you've created. If you've created multiple paths, it's good to tap. If it's just one path, you've got it right, we don't normally tap. So this being the convex side of the apex, there's no role of putting a reduction screw. So we're going to put a normal screw here. And then you have to just pass it in at the path of least resistance. As you notice, I'm not poking at all. All the poking is done at the time of the owl. This just has to walk its way in. Okay. Length normally is, this is slightly longer. We are seeing it from the outside, but we are just using it now for a corrective maneuver. The spineway system has screws that disengage like this. So it becomes quite non-fiddle rather than fiddling here. Now let's try the same on the concave side. Okay, concave side is going to be far more tricky. So my opening is going to be here. I won't repeat that. And it doesn't matter which direction. I'm just getting a good footprint because I don't want my owl to slip. That's the only, this is not causing any problem. Nibbler, right? The next thing I want to do is with a nibbler, take off the cortex of the spinous, of the transverse process, because this cortex will stop my angulation. But I know here I have to really medially angulate. This sits so proud that when I do this, it comes in the way. So I want to decorticate the TP. Then I take the lanky curved owl, and that's my entry point. Okay. Now cordocephalic, do you all agree with what this angle is? This looks perpendicular to the, okay. If it was here, it would have been like that. If it was here, it would have been like that. If it's here, it would be like that. Okay, so it's quite straightforward. As far as mediolateral is concerned, now this is a tricky screw because I have to really point it medially, but I'm really worried because the nerve is sitting right here. It's draped there. So one is that I go by the feel, which I'm going to go, but there are 2-3 other ways of solving this problem. One is that I put a screwdriver on this one, and this will tell me what the angle of this one was, and I get a much better idea of, I get a much better idea of what angle to take. So if the screwdriver is sitting here, support it. Now I know that this one will have to be like that in relation to the, it magnifies the angle of that screw. Okay, the other way of doing it is that you, after doing this, you actually correct this like a DVR. So you're de-rotating while you're passing the screw, making the pedicle far more easy to thread than in a pedicle that's converged. Sometimes you can even pass this side rod and do a correction and then pass those screws. So if you're totally stuck, I'm just not getting through, you use one rod for correction, finish the correction and then pass that screw. Okay, so first we'll just use the owl and start threading that pedicle. So what I'm doing is I'm going perpendicular and slightly more convergent. Okay, this is the angle that I'm suspecting should be right. At any point, if there's a non-uniform entry, like boom, I want to come back out. But this has been a very uniform entry. This is where the bone model lacks because you don't have that resistance of cortex and this thing. And you see how I'm moving, and at about 30, I want to stop. Then I get a feel. One is that feel. The other is the feeling of give way. The third is as soon as I remove this, I'll find bone marrow coming out. So blood and some fat. If it's not coming out, I've perforated something. If water comes out, I've perforated something. Then I use a hard probe to compact. Okay, now I may be going into a disc here, but I don't care. If I've gone too south, I'll be going into the lower disc, but I don't care because I'm fusing that area. As long as I've got a good bone hold. My medial cortex seems intact here, but better to take the soft probe. So the medial cortex seems intact, the lateral is intact. Inferior may be given way, but I don't care. Like I said, if I want to correct, I feel the inferior may be given way. So I will see from the outside. Yeah. Yeah. So I have, if I feel that, then I will correct it. I will take another trajectory and with the owl, slightly change my, so this way it was giving way. So I have one more shot at it, which is acceptable. Okay. And mostly you're able to get it. It's not like you're sealed out on one. Maybe feels better to me. I'm not seeing what you're seeing. But like I said, it's not so relevant. But now that I've made two holes, I'd rather use a tap here. And with the tap, try and get my, so I thought this was an error. So I'm doing this. Okay, forcing the tap. So the tap also can be used as an owl, by the way. If you can open up the cortex, the tap will guide you through the path of least resistance. Again, the feel looks good, so I'm fine. And then screw. Okay. So here we like to pass a reduction screw because this screw is going to lie far away from the rod. And if I'm using a concave rod to correct, my correcting screws should be here. So I'm using the reduction screw to show you how that rod will go. Now, is the rod ready? Length of the rod you will check. So here also I keep checking as long as I've got a good hold and as long as there's no neuromonitoring alert. Okay, so far so good. Any questions? So we'll just, I think we are enough screws for correction. One more here you should have. Anyone wants to pass? You pass on your models. So now quickly to get the rod length, we normally go by so the Swineway provides this malleable thing with a, with a ruler. So it's good to thread. Right now it's a chota curve, but it's a bada curve. The curve will be so much and you measure straight, it doesn't work. So you're going to measure within the curve. And the length that you get, you want to air slightly longer depending on how flexible you feel the curve is. It's a very rigid curve, you are not going to get correction. But if you're going to get correction, remember the rule of 70. Do you all remember the rule of 70? What is it? The rule of 70. Cutter, please. Went already. Okay. So rule of 70 is that no matter what procedure or what method of correction you use, what maneuver you use, if a curve that's bigger than 70 will distract until 50. Rule of 50, sorry. Rule of 50. So the curve, any curve will straighten up till it reaches 50 by distraction, whichever maneuver you use. So even I'm thinking I'm doing derotation, but the curve is lengthening. So any curve that's more than 50 degrees, you expect some lengthening to happen as long as you're correcting. If you're just doing in situ, it's different. Okay, if it's a curve less than that, you can just be exacting. Shorter. Chalega for now. Chalega. नहीं, इसमें भी चल जाएगा. So what we are doing is now we have bent the rod. This is not the ideal bend. It has to be like Cindy Crawford back. So here, this is straightened too much. So I'm going to just bend it. So what I will do is try to give her a Cindy Crawford. So normally one surgeon is enough. You got to eat, drink, and exercise to be able to do this correctly. Okay. I still feel there's hyperkyphosis at the bottom here. It's not how a normal spine should look. So I'm just flattening that out a bit. Depending on what is my lower level of instrumentation, I'll decide about the lordosis. But on the convex side, I'll err on a hyperconvex rod. Now the problem here is that this is still not balancing. If you see this rod, it's got a negative balance. So I'm going to further kyphose it at the top and then decide about the bottom. Okay, the natural flow is where the top should be in the same plane as the bottom. Okay, so now to get that, I'm going to slightly lordoze over here. You see what I've done? Now it's in one line. I'm reasonably happy with the rod. It's slightly more than less concave, sorry, because it's a concave rod. So when I'm using a concave rod, one of the methods of correction is to do that. When I do this, the more arc the rod goes through, the better the correction. So the deeper the kyphosis, the more that arc. The flatter the rod, it will not move any arc. Okay. So at the end, how far this sits from the top. So even if I'm doing a translation, the farther this is from here, the better the correction. And that's the reason why you want to over contour the concave rod. Exactly different for the convex rod. The convex rod is correcting by pushing in. Now, if it's already meeting, how much more can I push in? So you compare here, if I had to push this rod in, the excursion will be maybe a centimeter. But if I had an absolutely straight rod with nothing there, no curve, the excursion would be massive, right? So much correction potential. So on the convex side, you want to under contour. Okay. Now you thread. I'll show you the first method of rod rotation, which is the first thing that we learned when the 3D system came in. So as long as my rod is bent correctly, okay, I just thread the rod in first. There's no rocket science. Anyhow, it doesn't matter. It's not correcting. Okay, I get an approximation, kahan baith raha hai, which screws are sticking out, make adjustments to the screws, sometimes pull one in, sometimes use a long shank screw, etc. Okay, this mota moti is sitting in reasonably well. So then I'm going to start threading the screws. So a lot of us say, "Arey, nahi, better nahi karu." Mota moti, if it's sitting well, you start putting the knees and it will start coming in. Because then it'll be a combination of a cantilever with a rod derotation. Okay, so we're going to start putting the knees. Never full tighten the knees, just lock them like a cap. So one knee gone in. I'm just rotating the rod to accept the rod. Like I'm not worried about the correction just yet. I'm just accepting the rod. As you see, as the screws accept the rod, some correction will start happening because there's some cantilever, some translation, everything is happening. In the end, I want the rod to look as straight on the AP view as possible. Right now, it's looking all crooked, right? Sure, so if I had to do translation, sorry, if I had to do translation, this rod hold. Achha, we'll just put it in and then I'll show you. Forget it, it's fine. So when this goes here, it's again correcting. It's correcting. It's bringing the, so this was sitting out. The minute I take a rod pusher and thread this screw, because my rod has been bent correctly, no? By doing this, I'm actually giving correction. The lumbar apex has been brought in. Okay, now there are two screws that sit out that you all will see happening all the time. So the way to do it is rod holder. With a rod holder, first get the heads in alignment. Heads in alignment with the rod. Now with a rod holder, you can twist the rod to accept the screw. Okay, or you keep this as it is, saying this is what I want, and then take some kind of a reducer. Okay, can you hold this with a rod holder? No, with a rod holder. No, with the pusher. Then I try to do this, which means that I'm bringing the screw to the rod and not the rod to the screw, right? So with this, I'm bringing the screw to the rod. So we have this circuit device with this latches onto the screw, okay? And then with this, I'm trying to push the rod down back, okay? So it depends on which works. There's one more reducer. So this is a very easy, handy reducer. This is a far more powerful reducer. So if I'm doing this, I want to first put these innies in, okay? This will be like a translation maneuver. So let's put a couple of innies here and show the translation maneuver. So while doing this also, as you can see, the rod is sitting differently. If this was not a poly, we would be in trouble because this is a poly. We are able to tilt the head. Happening? If not happening, we can use that. So there's one more thing, you know, when you pass these screws, you have to keep them, screwdriver, keep them slightly long. Otherwise, the polyness of the screw goes away. Sada screwdriver. So this is too rigid. It's behaving like a mono. I want to pull it slightly back. Okay. I want to take this, see now it's become a poly. I want to take a nib and take off this excess bone. In the thoracic spine, it's the TP. In the lumbar spine, it's the facet. Now it's become a poly. Even here, I'd like to do that. So never push the screws deep, otherwise they don't behave. Now here, I'm suspecting the screws may not make it to the rod, so I'm taking the opportunity to pull it back a bit, also to make it more poly. Okay, because there are multiple holes, it's okay to do it. If there's one lumbar screw, to drag it back becomes loosening, right? And understanding so far or questions? So now when I pass this, put the knee इधर कहीं नहीं डालना So once these are in, I can use this as a cantilever maneuver to get this in. It is sticking out, so we may have to loosen those or remove. So with the cob, we don't have a cob here, but with the cob, I'm going to get this head in. And once this head latches the rod, I've got a translation that's happened. Even the other one. There. So here I will use a powerful reducer, which is converting a small shank screw to a tall shank screw. Okay. And as I do this, this goes all the way down. As I do this, it's going to pull the screw back to the rod. And that is causing a translation. So now I've already combined translation to the rod derotation. Now can you put the Nene here? Now after this, sitting. काय झालं? अजून वर आहे? नाही. This is a nice clean instrument to use. So as you see, can you see that? That the so it is translated or it little cover. Sometimes it will trim bone and all that. So for now, I'm just going to leave it. Okay. Now the next thing to do is a rod derotation. So bit of translation has happened. This either thoda cantilever bhi hua hai. And now rod derotation maneuver. Thing is to loosen the knees. Make sure all the knees are just sitting like caps, preventing the rod from pulling out, but they're allowing movement. So all are checked first. So even if one knee is not sitting well, no, then is sitting too hard. See now this knee is stepped out. So let's move the rod upper. Because you want to get maximum knees or maximum levels before when you do any corrective maneuver. Okay. Now, the first thing I want to make sure is that this guy is not slipping on the rod. It's holding the rod well. Always use two, so you distribute your forces. Okay. And you always will rotate in that direction, because to make this rod straight, if I go the other way, it will have to go through a 1, 2, 3/4 of a circle. Here is just 1/4 of a circle. The next thing is that I want to press the apex down. So first what we'll do is we'll just derotate. And when we derotate, you see what's happening to the apex. It's actually, as I'm doing this is actually moving up. Because it's uncontrolled. It's not controlled. So what we'll do is before the derotation, get some screwdrivers or some tower. Okay, maybe here I'm using a screwdriver. Anything to push it down. Earlier we used to manually push the rib hump with the hands, but this is much better. This is getting a better control. Okay, then one more. Anything. Tower. You can use a rod pusher also. You can use a head manipulator also. It doesn't matter. Something that goes all the way in and ensures that I've got a handle on the. And now one of you derotate. Is always then little jig, 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 jig. Yeah. Now you see the apex doesn't want to come out. Okay. Now keep your left hand unmoved and move your right hand. Open this with your right hand. So an assistant normally is needed to open it. That one is still controlling the rotation. And now pull it back here. Put it back all the way, as much as you can. I'm continuously pressing down here. Now keep this unchanged and read that. So your assistant can do it. This held, otherwise it springs back. And make it vertical. and go through the same process again. So soft tissue keeps giving, but you want to keep pushing it till you're able to get the rod as straight as you want it. And sometimes from the marks on the rod, you can make out whether the rod is actually moving or not. Nice, it is moving. Okay, now same process again. You'll slowly see it correcting. As the rod becomes straight, you've got your derotation. There are 2-3 reasons why it won't move. One is that your knee is tight somewhere. The other is that you've not done enough releases. The most common is that this is slipping. So you reassess, and these have adjustable turners. So you reassess and make sure that all 3 things are looked at. So absolutely, uske baad bhi if it's not moving, you have to change the correcting maneuver, change the maneuver, or accept under correction. It just moves that much. Like you may go through an arc of 50 degrees, but inside it could be just a 10-degree movement. It's a part of the whole game. Partly it's slipping, partly there's once it's holding well. The holder is not slipping. You know how to tighten the holder, no? You can turn this and the grip becomes stronger. You're getting a hang. So this is maybe this is one type of correction that we've got. Okay. Now let's seal it. Let's take this as a corrected. Lock the picture. Now the next thing that I can do is a convex cantilever maneuver. So after I've done this, I want to push this down. So now this is not so good. I want to get it even better. So I take the next rod. One more cut rod is there. Cut rod is there? Yeah. So one more thing I can do here right now is a segmental distraction, which I hate to do. So I won't do it. If it was convex, I could have done a compression segment to add to my this thing. But this I'm going to save for later. Segmental compression distraction I'm going to save for later. Total distraction I will never do, because that's going to really pull the cord. So at this point, if the correction says 20%, yeah, 30%, I want to do something more. If the correction was beautiful, if it was a very supple curve, I would have just finished it off there. So the next thing I want to do is use my convex rod to try and correct. So cutter. एवढी पण ह्याला माफ मारतोय. Right now we're just using these, sorry. So I'm going to cut the rod like this and under contour it. If you notice, we'll under contour it. Any questions? So I'll under contour this rod. So very subtle kyphosis. Always spread it over, okay? And don't let it turn in your hand when you're doing it. So that's why one person doing both the movements, make sure that you don't bend it in 3 planes. If you're holding and I'm bending, invariably it bends. Giving it a very chota kyphosis, chota lordosis. I'll keep reassessing. The push will be less, no? See, there's a pseudo kyphosis on the convex side. So the screw is sitting out. I want to push that screw in to get correction. If I contour it with good kyphosis, the push will be less. I'll demonstrate to you what I'm saying. So say this is slightly under contoured. Maybe I want to take it even less. I want to be slightly more aggressive because my side correction has not been so good. Right? So when I want to push this down, the farther away the more force I'll get. If it just draped around this, that I won't get that, right? So putting the knees on the top, one by one we start putting the knees. That Now here, because we are not going to go through a rod rotation maneuver, I've kept it in the correct line. So personally, I use the convex cantilever more often than concave rod derotation because it's a more powerful rod push. एकदम deep डाला है ना तो हिल नहीं रहा है. I normally use that as my workhorse, but each one can use theirs. That is a neutralization rod. Like I do my correction using a cross. I do my correction using a convex side rod. Lumbar spine. Now, because these need to be importantly aligned, important holding, I'm putting all the knees in and putting them well. Screw head tilt. Tilt the screw head with this. Just get the rocket. So double cantilever is ideal for a lumbar spine because the correction potential is very high. You notice this is in neutral alignment. It's probably not sitting. It's the other one. One bad one, one good one. So this has to become flat. That means it's sat. There's a gap there. So keep that away. Yeah, no derotation. You can, but derotation. So already I've put myself in favor of no derotation. Aram se hota tha to we could have done double rod also derotation. Now rod holder. Rod holder. This less fiddly. With this, with someone giving a counter, I'm going to do this. Can you see what I'm doing? And one by one, I'm going to thread the screws in. So in the end, I want to reach there. So there, if the rod was rotated, it would be a problem. So you see, it's brute orthopedic force. Take a pusher and see with the knee if it goes. It's quite straightforward. That's where a titanium rod helps. Slightly, it allows you. Like slightly malleable. Here, it would be good to have reduction screws. Here, if I was using a cantilever as my first option, reduction screws at the bottom would help accept the rod. We may even still do that.
While we need the screw heads to be aligned with the rod.
No, this is okay because I'm going to then thread it one by one. Like these three help this. 4 will help fifth will help sixth. नहीं तो rocker दे दो, rocker है. Someone have to hold. Can you hold this? Support this. So all these are all the practical problems that keep happening. You try this, try that. Nothing works. You pull the screw back. Nothing else works. Put a reduction screw there. Yeah. Here I'm not keeping them loose because there's no rotation. Again here. Sorry. Nene, I'm not derotating. No rotation means not that this curve doesn't have rotation, and we are not planning to derotate here. So remember, this never goes like this. It goes khada. You can see. Neighbors. pusher नहीं है। So now my job is to do that against a counter. You can see how the bones are moving. Okay. Now, since this is becoming tricky, what I could do is exchange this and put reduction screws. Okay. Screwdriver. नहीं, दूसरा side, right side. And just load it, reduction screws if available. So always I normally put lower convex lower 3 or 4 reduction screws, and that's how I plan my correction. So it'll accept this much better. But I'm going to leave this aside now. I'm going to not include it in a just to speed up. The last option would have been to over contour this, but then I'm missing out on correction. Yes, right? Reduction screw. Also, while doing this, it makes sense to release these a bit because it wants to come in, right? Just slightly loosen them. Hey, reduction screw. One more. You'll even pass screws on the other models. थोड़ा ही कर इसको भी हटाना पड़ेगा. To nibble away the TP also. काढून टाक. So I need to this one need हे कर. Otherwise the rod won't be able to thread, and sometimes even this you may have to remove. Next reduction screw, and then remove this also. This also in the remove. So I'm removing those innies because I want some clearance, clear space to thread the rod in. So I want that clearance. This was holding it down. So by doing this, it's too tight. By doing this, I'm getting in. We'll worry about that later. And we'll worry about these now because once it sits in, I can't do this. So I want to get these in and then get the. So these are roughly in. Okay. बहुत दबा मत because इधर दबा नहीं ज़्यादा. So what we do is now see these are friendly screws because reduction screws. You just stabilize this and let me work hard over here. This is where that rocket and all will come into play. Rocket is there. But you all notice how it's now straightening up. And as I put this in, it will straighten up even further. This is not tight. This is also tight. You're right. So इसको भी इसको lose करना है. इसको नहीं दबाने को to go to the longer lever. Hold here. Hold here. नहीं here this one. And thread that in. Thread this one in. All the way down. Go. Like this. It's that much force that you have to put in. The rocket is there. This is the good rocket. Where are the leggings? Size the small spaces. The next I want to show you is the DBR. How to do DBR after this. Sorry. You put the innies. I get space here. Innies done. I'm looking hand cross over. Give a listening. Oh. The medial screw. Let's try to do it. Shortcut में नहीं होता है तो वो करेंगे. निकला. The fairly meat निकल. Now it's sitting in. I'm just creating some room for my reducer, but I need to get these screws also in. I'll just try the rocket once. It's not giving me too much room here. We'll try rocket. Because this is actually pressing that apex in. So I need these also to be working for me. So normally I would use a ronger. We can have a ronger here. And we didn't show you the osteotomy. No? Drill आहे इकडे? वर आहे. Still it's like once this is done, for DVR what we do na, is we tighten the first two. Final tightener, we have final tightener. So we take the final tightener to lock the top two. We start always start from the top. Any towers आहेत? DVR से towers? Okay. मग screwdriver. We can use these. Take a final tightener. Final tight. And second we'll use this. This is a flop one. We'll use that one. I'll show you. They're final tightener. Assuming that these two are final tightened. Okay. Now where's the final tightener? Now we do this and just loosen the other. Actually, it doesn't matter. The others can be as they are. So I've used two things to elongate the screw head. Who's fixed? The innies have been loosened. Right. So these innies are loose. These are independent. Ideally, they're tight because I just have to move this. Okay. And someone has a control on the rod. Rod holder say, make sure the rod is not going to move. One more screwdriver. Yeah, both rods get a control. So because this is tilted like this, no, I'll be twisting it here. You tend to twist the rods on that side. Idhar bhi pakad le. And this guy is trying to do that, and I'm trying to do this. Can you see? Can you see that bone also twisting? Got it? And then I tighten. Yeah. Towers are suited for this because towers can be interpreted. Now towers nahi hota hai bahut baar. So this is a jugaad method. So ultimately you have to elongate the head. Understood? Now I'm just show you one more. Just loosening these. ये पूरा ढीला किया. हिरण्यकश्यपु. कौड़ों के रॉकेट कौड़ों के
they also tell you how much you can drive an officer, which is figure what needs to be done. So
now here I'm going to use this one as my tower because this sits on a reduction screw better than that. And idhar kuch bhi nahi because this is not sitting, so I'm going to use a plain screwdriver. Maybe this because this is now become one unit, my screw head. Okay. So both are loose. You're twisting it that way and twisting it this way. Ideally, same surgeon. So push this down. You see that bone twisting? Now you tighten this. So that's how you do the DVR from top to the bottom. And finally, the in-situ benders are. Once all this is done, you can let go. I just want to show you because you need some hands-on time also. I'll show you how in-situ bending is done. So we saw some derotation, saw some DVR, saw some translation by the long shank screw and the cantilever. For me, the safest good method is cantilever method. So because it's pushing, it's not pulling. It has a tremendous correction potential. For that, I use a COCR rod. So I would put my screws, take a COCR rod on the convex side, use reduction screws at the bottom 3 or 4 places, and do just what you all saw me doing. Start threading bindas. बहुत बार है ना, ultimately आ जाएगा. जितना the more it's out, the more the correction. So the rod sits like this, then it comes here, then it comes here. You keep giving yourself and finally to correct hypokyphosis. Now you'll have to just steady the spine. Maybe in situ bender is used like this. So I want to correct the lordosis, make this more kyphotic. So I do that gently. It's easy on the titanium, difficult on the COC. And I'm doing this all the knees is bending, and as the rod is bending, so in this rod it will bend in a third dimension because the rod is not derotated itself well. This will turn out to be a 3-dimensional bend, which you don't care because this is the last step of your. Understood? Similarly, I'd like to give a lordosis. Here, so I'll do this. You don't have to do this in all, but I'm just showing you. This is giving a lordosis. It's a very powerful maneuver. Be careful and not. Yeah, it's not fixed, but this is how we do it. Okay. Or I like to do throughout, like top to bottom. Here you have to rotate the other way. Here we are doing that. Day you have to do this. Just remember that. So if I have very good screw holes, do one screw. So that's my go-to. But sometimes screw holes are not good. Can be 1, 2, 3, 4, 5, 6, and then they get connected with each other, and the whole thing moves. So overloaded. If one is getting overloaded, can cheese through. But I don't like block. I like one at a time because the correction potential is much better. But for that, my screws have to be strong. Yeah. Any questions? Rotation always in one direction. The convex to concave. If this is like this, the rotation has to go there. The question is what? Always flattening the convexity. So here it would be like that because here the convexity is there. So here I would do that. No, I always like cantilever. You can do one as a workhorse. You can't do 3 procedures as a workhorse. Reduction maneuver. So if you choose if it's a floppy easy curve, we're going to show you there's a better model there. There's only one, which has actually a rotation. This didn't have a rotation, so it was not derotating. This is a flat model. So if it's a floppy curve, I can just use a rod derotation as my maneuver, in which case I need good screws on the concavity. I ideally want reduction screws at the apex of the concavity. So some translation also come in, and I don't put my convex rod till the end. All the correction is achieved, and then I put this as a neutralization rod straight in. The translation alone we nowadays don't use. For the side loading, we used to use translation alone. I told you cantilever, so I don't do anything here. I just release and then do this. Net compression distraction happens. Distraction, elongation. But if the curve is less than 50 degrees, it won't happen. But most of our curves are, so invariably you need a longer rod. If you take a cut to cut rod, you'll see the rod is getting over. That's when you see the pliability of the curve. Anything else? Yeah, that drill is there. Drill and foot switch. So Ponte will involve taking this down, this much part. Okay. After that, you have a choice whether you want to take this down also or not. I'll show you thoracic also. Once the drill comes, please tell me. Drill is here and a foot switch. That's it. So always nowadays these piezo ultrasonic cutters are available on loan. So don't do Scoliosis with that. It's one of the most, monitoring is the most useful next instrument in Scoliosis. So piezo cutters are available on rent. So I've demonstrated here, I'm going to do it here. So you do with me.
Sundays usually are
So after I've taken the yellow ligament, I'm seeing the epidural space. Huh? Achha. So I'm just going on the bone. This bone is very safe to remove because there's bone below. There's no, area of discomfort below this. हम लोग osteotome से निकालते हैं T-lift के time, right? So this bone is never an issue. The next one becomes an issue. So once I've done so much, I should see the glistening surface of the whole thing should come out. Sometimes the flake remains, that's not good enough. This whole thing has come out. Now I'm seeing the glistening surface of the lower facet. Now I have a choice of leaving that alone because this already has given me a lot of room, but I like to take it off. So the best way to do it is with an ultrasound cutter, zoom, because then distally there are epidural vessels which get coagulated when you're using an ultrasound cutter. If I don't have that, instead of a burr, I can use a forward punch. So use a forward punch and start going distally. There's no punch, but I go this way. And till how much? Till I get a give. There's nothing laterally, so that give doesn't matter. So keep removing, and then that give comes. Okay. In reality, it will end up like this. So this is important because below this is the nerve root and bleeders. So I can't thrust in. Here I could have thrust in. Here I have to be very light-handed. And this is exactly what you do for a TLIF. T-lift, so much bone you have to remove to get into the space. Now you'll see the nerve root right there. So if I had gone thrust in, I would have taken. Now this gives me a much better closure. When I get the closure, I get my kyphosis. Okay. Now I'm going to show you one here. First, I'll show you on a place where no screw has been put. Maybe here. This may be a good place. So here the facet is like this. It's like a C shape, different from there. So my line of osteotomy will have to be like this.
eventually if you start a practice of your own or something, then we have like a WhatsApp.
Got it? That's how the inferior articular process of the superior vertebra will be. So I'm literally going there. Again, ideally with an ultrasound cutter, which will actually cut the bone without bleeding. And in one clean piece, I get a chunk of bone for my fusion also. Once this is done, again, I see a glistening surface of the facet below. My assessment is I can go still more medial because there's still a lot of bones. So I'm going to drill the medial end down a little bit more. After this, I have a choice. Leave it alone and accept this movement. Now here, because you have not exposed the middle canal like you've done in the lumbar spine, it's safer to go lateral to medial. If I want to now finish this osteotomy, I'd go from the outside and take a forward 2 number and start biting inwards. If I have a drill or this thing, I'm going to go from outside to in. So how much superior inferior? You know roughly where the pedicle entry point is, right? We discussed. So up to here, everything can be removed. Pedicle to pedicle, everything can be. So superior inferior extent is pedicle to pedicle. Ideolateral becomes a problem. Now I'll just show you what that problem is. So what I've done is जो भी दिख रहा है मैंने निकाल दिया हूँ. Okay, this is not a ponte. Though I've gone through both the layers. the full medial wall intact. So this is not a ponte. I'm not seeing the canal. In a ponte, I need to see the canal. So now I'm pushing this further in. Got it? I'm going more medial till I see the canal. Now you will start seeing the canal. Can you see the canal now? Can you see that? That's the canal there. Now I need to remove that, otherwise it's not a ponte. That is going to block my. So again, from the outside to in. And because now I'm working towards the neural elements, if this was an ultrasound cutter, I would be safer. Else I'll use a forward punch, but not a drill. This is a full ponte. Here you don't end up seeing the yellow. You can see it. You have to expose this thing. I mean, I kept the spinous intact. If you take the spinous process off, but because it's so overlapped, no, it's not like this where there's a big open window. There is a very small window. So you rather go lateral to medial and finish it rather than medial to lateral. Concave minimum, but both. Concave minimum. I think I do concave full and convex half. Just one facet, not both the facets. On the convex side, I just have to create room to close. On the convex side, I mean convex side. On the concave side, I need a full play and something to give a better kyphosis. Because concave side is the cause of the hypokyphosis. So if I pull that out, I'll get a good. Okay. Sorry, one more thing. So I told you I use this as my main reduction rod. Once this is done, I still want to get kyphosis from there. So there also, if I have a nicely contoured rod, and I start threading it this way, there will be some posterior translation happening. If I've done a good ponte and my screw hold is good, it will pull that back. Just like if you had to use this as the correcting rod, this would help to push this down. You want to use this to help pull it back. And for that, your releases here and here have to be good. Remember, the ribs will tether this down. So you have to cut those ribs, release that, and then attempt to pull this back. So the lesser the releases, the lower your stakes, the more you accept. The more the releases, the more normal you can get the curve. I'm not advocating to get a normal curve. You do what your skill sets allow you within the safety, but the more you do, the more you will get. Okay. Now, depend on what maneuver you're using. So if I'm using a cantilever maneuver, I would use no reduction over the last 3 or 4 reduction. If I'm using the concave side as my correcting rod, which is a single curve, a curve that is quite flexible, screws are not so good, and I would use non-reduction, non-reduction, reduction. We're going to pull this there. You're going to push this down. Clear? You're going to attack now. Attack a bit. We are here, so you'll get there 2 stations. You can pass some screws also. And pass screws also. One day.
Yeah. No, Daftari was available. She doesn't. How many bottles did we manage? Okay. Yeah. But your day took a lot of pictures today too, no? Oh. Okay. All right. Okay, if I can find out from someone, if I can still send some ways, then I'll do. Yeah. नाही आता आपलं ते प्रेझेंटेशन फक्त स्क्रीन केलं तरी होल्डिंग स्लाइड हो बाकी
Discontinue to the Zoom now, and thank you the faculty and the audience who were attending on Zoom, because we're now on hands-on where there will be not much utility for you guys. So thank you for being with us and sharing thoughts and participating. And we are open to discussions after this. We're going to make an email forum and we'll continue discussions here on. Thank you again.